Good morning and welcome. How are we doing on volume? Good. Board members, we have new microphones and I've been instructed to tell you to leave them where they are because they can pick us up from this distance. So appreciate that minor detail, but just appreciate again everyone being with us, and know a lot of work happens in between our board meetings with the advisory committee, as well as just a number of follow-up and conversations that we're having. So thank you to the staff as always for preparing all the materials for our conversation, and for all of you for your commitment to healthcare affordability across the state of California. I will ask for us to call the roll, please.
Good morning, Dr. Sandra Hernandez. Secretary Kim Johnson. Here. Richard Kroenig.
Here.
Ian Lewis.
Here.
Elizabeth Mitchell. Here. Dr. Richard Pan.
Present.
Don Moltz. All right, 5 present.
Great. Well, we have established our quorum. Director Landsberg, I will turn it over to you. Thank you.
Thank you very much, Madam Secretary. So I'm just going to go through today's agenda briefly. So following executive updates and approval of the March meeting minutes, if you see fit, we'll have a walkthrough of the cost and market impact review of ResCare. So this is our first completed cost and market impact review. So appreciate that we're joined by Brian Kearns and someone who worked on the transaction to do that presentation. And then we have a quarterly update on the CMIR program in general. After that, we'll briefly go through the spending target data submission enforcement regulations, which have been posted. We'll move on to spending target enforcement with an introduction to spending target penalties. And then we will end the day with a hospital measurement update, specifically inpatient and outpatient hospital spending trends for 2022 and 2023. So we have a lot on the agenda, so I'm going to keep my HCI updates brief and just want to cover 2 things. First is that last Thursday in this room with a much larger table, we had the first reconstituted Data Exchange Framework Advisory Committee. So folks will remember the Data Exchange Framework was incubated at the Health and Human Services Agency, was moved administratively to HCI last August. New legislation was signed by the governor, Senate Bill 660 by Senator Menjivar, increasing and really laying out the next steps for Data Exchange Framework. I think it's important to keep this body informed of that because I do think Data Exchange Framework is an important affordability measure. We do see people who get unneeded duplicate tests. It's really critical to have that sharing of information for people to get the right care in the right place at the right time. So we have a number of duties and legislative report that we have to put together on next steps on Data Exchange Framework. And then my second update is about the Rural Health Transformation Program. So I'm pleased to report that at the end of March, CMS unrestricted the remaining $50 million from our award. So folks may remember they had approved all but $50 million. That $50 million we had proposed in transformative care payments to hospitals to help them participate in the Rural Health Transformation Program. CMS said those were considered provider payments, which are limited to 15% of funds. So we had to both change the amount that was available for those down to $35 million for transformative payments and put some more structure in place that CMS was requiring. And then we reallocated the $15 million remaining dollars to strengthen already approved activities. So with those changes, CMS has released all of California's funding. We hosted a webinar yesterday about the Rural Health Transformation Program. We maxed out at our 1,000-person. Apparently our Zoom account only allows for 1,000 people, and we did have 1,000 people register for that webinar. So there's a lot of interest. And so we will be releasing requests for application for the transformative care model and the workforce development initiatives in late spring, early summer, and had a lot of questions and a lot of engagement on that call. As I was leaving my office upstairs, the team was on a call with CMS, and we've had good conversations back and forth with them on that important initiative. So those are my HCI updates, and with that, I'll turn it over to Vishal.
Thank you, Director Landsberg. My first update is that the Total Healthcare Expenditures Data Submission Guide, or DSG 3.0, emergency regulations became effective yesterday, April 20th. Or April 20th, which was Monday. The regulations can be found on OCA's website. Now I'll turn to the quarterly work plan. So we've gone over today's agenda. So I'll go over some items we have for May, which include a continued discussion on spending target penalty, a status update, and review of comments received on the spending target data submission, penalty or enforcement regulations, a discussion about the CMIR regulatory changes as a result of AB 1415, a cost reducing strategy presentation by Providence, and an introduction to the equity and quality adjustments for the spending target. In June, we have continued discussion about spending target penalties, a report on healthcare spending trends for 2023 to 2024, an update on the non-supervisory organized labor adjustment and assessment, an advisory committee membership vote, an introduction of the CMIR regulatory text, and an update on the HCI Health of Primary Care in California snapshot. For future topics beyond June related to total healthcare expenditures and the spending target category, we'll have a board vote on the spending target penalties plus the start of the process for penalty regulations. We'll also explore, as part of our cost driver analyses, variation in utilization intensity, as well as regional variation in commercial prices for shoppable services. For the category of promoting high value, we will review the 2023 to 2024 alternative payment model adoption and primary care spending. So this is based on new data that we collected last September. We'll also provide an update on the primary care snapshot that I mentioned earlier, and an update on behavioral health spending analysis and benchmark. And turning over to the market consolidation category, we'll provide an update as we're doing today on material change notices received, any transactions receiving a waiver or warranting a CMIR, and how much time is taken to review those notices and conduct CMIRs. And then we'll also provide a status update on the updates to our CMIR regulations.
We have a question, Deputy Director.
Thank you for the update. Is there any plan to look at administrative costs with health plans?
That'll be part of the 2023, the June report that we hope to release on 2023 to 2024 spending. So we'll be reporting on health plan administrative costs and profits.
So that will be part of the target and the methodology and everything, because I know that was an equally important area of focus.
Yes, it's that those categories of spending are subject to the target. And last month we did present some early analysis of 23 to 24 societal filings for MLR. And then we did derive the admin costs and profits both on a per member per year basis as well as aggregate basis. And then we'll be including those findings again in the June report.
Thank you.
So related to that, I know that it's come up in previous board meetings, and I know it's sometimes a bit of a challenge, but so we talk about the admin costs for plans, but spending by healthcare providers often is all classified as quote, medical or whatever the spending, but we know there's admin costs being pushed down that on the provider level, right? So you think about how big the billing departments have to be in hospitals or medical practices, actually even sometimes having to fire staff to do that. And we know that actually many physicians spend most of their time doing admin, not patient care. So are we working on trying to figure out how to capture that part of the admin costs too? Because that's adding to the spend.
That's not the scope of activities for OCA, and it's just the way the THCE is defined. So it is, you know, payments to providers, which counts as the total medical expense part, and then we are charged with looking at health plan admin costs and profits. But I do acknowledge that there is,
Well,
not just what you're saying about provider duties on administrative tasks, but also the delegated arrangements. And there's questions about how much of that is medical care versus administrative costs and profits.
I know it has come up before, but I hope that there's nothing that says we can't take a look at that as far as I recall. And to simply classify all that spending as medical care, I think is a missed opportunity. And basically now you create an incentive to try to push as much administrative cost onto the practices, because that one, first of all, if you classify it all as medical costs, that creates a bigger baseline for your percentage you're allowed to do for profit and admin at the plan level. So so I do think that we should make some effort in trying to figure that part out, especially if it turns out it's substantial, as we're trying to get our total healthcare expenditures down. Because if it just gets pushed down to the provider, we're not making progress.
I think it's a really important issue and appreciate the board raising it. I'm not sure we have the legal authority to require hospitals and medical groups to report at administrative costs and profits. I mean, I think there have been attempts to do MLRs at the medical group level and the like. So I just want to caution that we do have a lot on our plate. We can certainly look into what reporting would require and very much understand the importance of it.
And not to pile on, but I completely agree with Dr. Ban. And as you look into the costs that are attributed to medical care, I mean, when you see things like Kaiser and Sutter making multi-billion-dollar acquisitions, where does that show up? I mean, because clearly there's resource somewhere that may not be in that, 3%. So is that part of administrative costs? Like, how are we reflecting some of those other costs that employers and patients are certainly bearing, but aren't necessarily being caught in the current methodology?
Yeah, it wouldn't be captured in the way we're measuring healthcare spending. They can certainly, they may be financing those acquisitions in a variety of ways. Some of it could be using the reserves. But we're measuring payments to providers, for patient care. So it's a little, it's out of our scope, but our CMIR program certainly kind of looks at how these transactions are financed and how these deals come together.
Yeah, Elizabeth, as Vishal just said, although we say we're targeting costs, we're really targeting revenues, which I know but just as a reminder. So the kind of what healthcare entities are spending is not really what we're measuring. We're measuring with the revenue that they're getting. And I think to Richard and your exhortation on the importance of trying to get some understanding of administrative costs and profits at the medical group level. I kind of third the exhortation and comment on the difficulty of doing it in a systematic and really precise way. I mean, 20 years ago, I published an article with Jim Kahn and others estimating administrative costs for hospitals and medical groups in California. And, I think it was, given the resources we had, a kind of reasonable estimate, but based on kind of survey data and some other data sources, it is the kind of thing that a foundation might well support if a person knew any foundations. And maybe something that the office would have, resources to do. But I think it would be, it would, to get it on a systematic basis at the medical group level would require a whole different kind of data collection than we've done. And as Elizabeth said, not clear that the office would have authority to do that.
I do sympathize with that. I just want to make sure we're not looking under the lamppost because that's where the light is, because these are clearly contributors to the affordability crisis. And I'm sure there are smarter people than me who could figure out a methodology, but I just think not looking at it misses a big source of the cost problem.
I agree that we may not have the statutory authority to basically require certain types of data collection, et cetera, but perhaps there might be, as I think Dr. Koenig suggests, some efforts or attempts to put some resources together to investigate this because, well, let's put it this way, statutory authority can always be gained or changed too if there is some good data behind the reason for doing that. So, so maybe we can encourage people to look at this so at least we have some idea of what the scale is, and if that scale is such that warrants more action, then maybe that would be prompted. Thank you.
So I'll take us to our last slide in this section, which is our slide formatting key. Yellow areas indicate presentation areas for which OCA has decision-making authority. And then the green arrows are where the board has ultimate decision-making authority.
Great. Thank you for those executive updates and for that discussion on things we might want to dig into a little bit more as we're looking ahead. I will now first recognize Sandra Hernandez has joined us, and thank you for being here, and also then go to public comment on this item.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period at the end of today's meeting. To ensure equitable access, we will alternate between members in the room and those attending virtually. Please line up at the podium or please raise your hand. If you're dialing in, please press *5. We also invite you to provide written comments at the email posted on today's public agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that's not included on today's agenda, except to place it on a future agenda. I will start with the individual at the podium.
Beth Capel, Health Access California. Well, we thought we'd escape public comment on this item, but thanks to the board, here we are. We would note that Dr. Khan has updated some of that research in recent years as part of the discussion that the agency has conducted as a result of implementing SB 770. And so I'm not clear on what's in the public domain as yet and what's not, but it is ongoing work that's available and that drew from a number of peer-reviewed sources. Second, we did in our letter in a prior month raise the issue of administrative overhead and costs for providers and for systems. We note that the OCA does have authority to require audited financials, which a financial statement would show things like reserves and $9.3 billion in interest in investment income for an entity. And that these administrative costs, whether it's on the provider health system side or the plan side, are contributors to the problem of affordability, as the board has said. Finally, we'd note, as we have done in prior letters, that there is a specific target on plan administration and profits that says that if a plan exceeds the target, then there are limits on the administrative costs and profits. Dr. Pan may remember this as an important provision that we thought was an important third set of penalties for consideration. So we look forward to future discussion with the staff and the board on this. Thank you.
Thank you. Looking virtually and seeing no hands raised, we'll go back to the podium.
Yeah, Brad Schmidt from Northern California Pet. One idea, I'm not sure if this is the right form, but just maybe bring it up in the future. I'm a provider, health provider. I used to have a company in Medicare, Inglewood, California. I now run Northern California ambulatory center here in town. We get money from the state. One idea I discovered last couple of times I got money from the state this is from CHAFA. We were getting a couple $1 million for a small loan for a PET scan technology purchase. The health systems were in front of me. One got $1 billion, one got $500 million. They're borrowing money at 4%. When I researched what they charge for commercial in particular, it could be 1,100% higher. And I was thinking, like, if you're borrowing money from the state at 4%, perhaps there's a mechanism to basically sell it, like put a governor on how much you sell it for, say 300% or 400% or whatever that number is, to kind of help lower the overall costs. So I just want to throw it to the room. And then secondly, there's a website called Sage Transparency. A lot of the economic data is transparently online. It's free. So if anybody's looking for margin rates or margin pressure, it's all available online. Just want to show it to the room. So just a couple ideas. Thank you.
Thank you. Looking back virtually, seeing no hands raised, I'll give it just a moment. No one in the room. That concludes public comment on this item.
Thank you very much. We'll move on to item 3, our consent items, and I'll turn it back over to you, Deputy Director.
We have the March meeting minutes, the minutes and public comment received since the last meeting have been distributed.
Thank you. Is there a motion to approve our consent item number 3 for our minutes?
So moved.
Open it up for public comment.
We'll now take public comment on this item. Please step to the podium or raise your hand virtually. Give it just a moment. Seeing no hands raised virtually, we have about almost 100 virtual attendees. No one at the podium. That concludes public comment.
Thank you. I'll call the roll for this vote, please. Do we need to do that?
Excuse me. I was writing down who did the motions. Thank you. Dr. Sandra Hernandez.
I need to abstain. I wasn't at the meeting.
I'm sorry, was that an abstain?
Yes.
Thank you. Secretary Kim Johnson.
Abstain.
Richard Kronik.
Approve.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
4 in favor, 1 or 2 abstain.
Thank you. Motion passes. Thank you. We'll move on to now our first informational item. This is item 4. This is about the cost and market impact review of ResCare. This item will be presented by Brian Kearns, the Assistant Chief Counsel, and the team from Bates White.
Good morning, everybody. I'm Brian Kearns. I'm one of the Assistant Chief Counsels for OCA's Compliance Division. So I'll be as Director Landsberg discussed, I'll be talking about OCA's first completed cost to market impact review, and that's of the ResCare and Savita transaction. I'm going to provide just like a brief overview of the transaction, and then I'm going to actually turn it over to Bates White, which is our consultant who performed the analysis. So on March 23rd, ResCare, a subsidiary of Bright Spring Health Services, filed a material change notice with OCA to sell its subsidiaries and assets to National Mentor Holdings, the parent company of Savita, for $835 million. So essentially, this transaction combines 2 large national providers of services for individuals with intellectual and developmental disabilities. Both companies operate hundreds of intermediate care facilities for individuals with intellectual and developmental disabilities, and home and community-based services, including adult residential facilities and adult day programs across the United States. There are a lot of acronyms involved in this review, just so you know. We're going to do our best to not use acronyms. When you view the report online, there's an index that has all the acronyms that are used throughout the report, which is very helpful to look at when you're going over the report. So there's also multiple private equity firms involved in this transaction. Multiple firms hold an ownership interest in Savita. As part of this transaction, the private equity firm Centerbridge Partners would acquire assets and equity from BrightSpring through its subsidiary National Mentor Holdings. Next slide, please. So in California, ResCare operates 75 intermediate care facilities, 11 adult residential facilities, 6 adult day programs, while Savita operates 20 intermediate care facilities, 53 adult residential facilities, and 54 adult day programs. So after our team conducted the review of the material change notice, OCA determined that a cost and market impact review was required because the proposed transaction may result in the following: potential reduction in the availability and accessibility of services, diminished quality of care, increased costs for payers, and potentially contribute to an ongoing consolidation in the healthcare market. Next slide, please. The review started in December 2025. Pursuant to OCA's regulations, the CMIR examined a variety of factors relating to the healthcare entity's business and relative market position, including the impact on competition and potentially how the transaction creates a monopoly, which could result in increasing costs, reducing quality or equity, or restricting access or innovation. We also looked at the effect on competition for workers and the impact on the labor market, the effect of the quality of healthcare services delivered to any of communities affected by the transaction, how the transaction impacted the availability or accessibility of healthcare services to any community affected by the transaction, and any consumer concerns, including but not limited to complaints or other allegations against any healthcare entity that is a party to the transaction related to access, care, quality, equity, affordability, or coverage. Next slide, please. So our OCA released the preliminary report on March 10th. It outlined our OCA's conclusions regarding the transaction's impact on costs, quality, accessibility, and market consolidation. For our regulations, after issuing the preliminary report, OCA accepted public comments from the public and the parties for a period of 10 business days. During that comment period, we received one comment supporting our preliminary findings. The letter also expressed concerns regarding Savita's quality of care issues and financial practices. We released a final report that did not make any changes from the preliminary report in response to the public comment. That final report was released on April 8th, 2026. Next slide, please. So as I previously mentioned, we engaged the healthcare economic experts at Bates White, which is an economic consulting firm. And at this time, I'm actually going to turn it over to that team to introduce themselves and to go over their analysis. Go ahead, Nitin.
Good morning, everyone. I'm Nitin Dua. I'm a partner and co-chair of the Antitrust and Competition Practice at Bates White. I'm an economist here. I work on review of merger transactions, the antitrust risk associated with those, and present those results in various forums, including government agencies like Department of Justice, Federal Trade Commission, or in courts when presenting results of the analysis specific to litigated transactions. I was assisted by my team, Saurav Karki, who is not here, but I do have my other two team members joining me, Anirudh Jayanti and Michelle Lam. I believe both of them are online right now.
Hi, everyone. My name is Anirudh Jayanti. I'm a manager at Bates White, specialized in life sciences and healthcare matters, particularly as related to antitrust issues like mergers. So I'll pass it over to Michelle to introduce herself.
Hi, I'm Michelle. I'm a senior economist at Bates White, and I primarily specialize in healthcare mergers.
Next slide, please. I guess I should say thank you all for giving us the opportunity to present our findings with respect to the CMIR. To begin, I'll just provide you high-level key key takeaways and then get into some details. As Brian already mentioned, Savita and ResCare serve Californians with intellectual and developmental disabilities. Because it's a bit of a mouthful, I may resort to sometimes using the acronym IDD services for them, but I'll do my best to avoid that usage. The services at issue here are provided at three main care settings: intermediate care facilities, adult residential facilities, and adult day programs. Our analysis shows that this transaction is unlikely to lead to a significant change in competition for provision of these services. As a result, change in competition is unlikely to lead to an increase in healthcare costs, harm competition for labor, or lead to a trend in consolidation. However, because Savita has a particular operational history and a financial approach, there are some concerns that do arise with respect to its quality performance. And if those quality performance issues were to extend to ResCare facilities, the transaction could increase the risk of reduced quality and access to IDD services. Next slide, please. So here's how I've structured this discussion today. First, I'll provide you with some context on the landscape of these services. Then I will provide our analysis with respect to competition. That is how the transaction would impact the competition for provision of these services and how whether that change in competition can impact costs, labor markets, or consolidation in this industry. And finally, I'll turn to the key concerns that this transaction raises with respect to quality and access. Next slide, please. And one more. So as I said, three main care settings. First, we have intermediate care facilities. These are 24-hour residential and healthcare services. These are facilities that provide 24-hour residential and healthcare services, including skilled nursing care. Within different types of intermediate care facilities, there can be variation in intensity and continuity of skilled nursing services. Second, we have adult residential facilities. These are community-based settings, unlike intermediate care facilities, which are institutional in nature. At adult residential facilities, individuals receive housing and supervision, but not skilled nursing care. And then the third category is of adult day programs. These are non-residential programs that provide individuals with daytime care, structured activities, and social engagement. Next slide, please. So as this chart shows, the services provided at these three service types are distinct, and they are meeting different individual needs. For instance, if you're an individual who requires or whose family requires for the individual to receive residential care and have access to skilled nursing care in an institutional setting, your only choice is an intermediate care facility among these three. While if you are seeking community-based setting for the individual in question, and the individual doesn't require skilled nursing care, then an adult residential facility may be a better choice. And if the choice is to, if the requirement of the need of the individual is to receive structured activities on a daily basis, but not a residential need, not have no residential needs, then an adult day program may be a better choice. These distinctions matter because they inform our choice to analyze competition separately for each of the three products here, rather than treating all of these services provided to individuals with intellectual and developmental disabilities as part of a uniform market. Next slide, please. So funding for these services, specifically intermediate care facilities, come through Medi-Cal managed care, California's managed care Medicaid program. For adult residential facilities and adult day programs, these services are covered by Medi-Cal under its home and community-based services waiver programs. The Oversight and Regulation Authority is split across several agencies, including Department of Developmental Services, California Department of Public Health, Department of Healthcare Services, and California Department of Social Services. Service coordination itself is carried out by regional centers, which are themselves nonprofit entities that determine eligibility. They look for a need for vendors. They contract with vendors or service providers. They coordinate with individuals, help develop individual plan program for their service needs, and then help coordinate their choice of the facility. Next slide, please. Moving on to the merging parties here, and beginning with Savita. Savita is a national entity, as Brian mentioned before, and has its footprint spanning several states in east, south, as well as west. We have California, Arizona, Texas, Louisiana, for instance. Overall, Savita owns about 250 intermediate care facilities across the country, about 800 adult residential facilities, and around 175 adult day programs. In California, it primarily operates adult residential facilities and adult day programs, and has only a few intermediate care facilities. Next slide, please. ResCare's footprint kind of closely resembles that of Savita's. Its footprint also spans several states, including many where Savita is present, like California, Arizona, Texas. Nationally, ResCare operates around 500 intermediate care facilities, over 1,100 adult residential facilities, and just about 25 adult day programs. In California, ResCare primarily operates intermediate care facilities, but it does have both ADPs, that is adult day programs, and ARFs, that is adult residential facilities. Next slide, please. I will now move on to our competitive impact study, or competitive impact piece of our study. I'll begin with an analytical framework and then present some results. So mergers alter what economists describe as market structure. Market structure itself refers to things like number of sellers in a market, their pricing strategies, their products, and how differentiated their products are, how easy it is to enter or exit in those markets. And what mergers do is they can, depending on the extent of competition that exists between merging parties before the merger, they can impact relevant outcomes like prices and quality. So for if there's greater competition before the merger between two merging parties, then it's likely that the impact from loss of that competition will also be greater. This is what economists refer to as competitive effects. One way that competitive effects are analyzed is by looking at changes in market shares and concentration. Concentration itself is referring to both the number of providers in a market as well as their relative sizes. And assessing the extent of change in market structure can help inform the likely impact on prices and quality and other outcomes that consumers care about. But to define market shares and concentration, you first need to identify what is the relevant product and what is the relevant geography in which that product is offered to consumers. And the shape of these relevant geographic and relevant product markets is often determined by how consumers view the closeness of substitutes of the products in question as substitutes, and how far are consumers willing to travel to consume these products or services. Okay, next slide, please. So in line with that idea, we first define both relevant product and relevant geographic markets. As I foreshadowed already, our relevant product markets are, there are three of them. One for intermediate care facilities, second for adult residential facilities, and third for adult day programs. They are distinct because of how consumers view them and how the regulatory supervision of them and the regulatory oversight impacts the choice of these services and where these services will be consumed. For relevant geographic market, the question of interest is what drives the choice of these services. In healthcare and across many other products, consumers tend to have an aversion to travel time. There's a reason competing providers often locate close to population centers so that it's easy for consumers to access those services. When we look at adult day programs, they require frequent travel, and it's likely that to minimize travel burden, families and individuals would seek adult day programs that are located close to them. When we think of intermediate care facilities and adult residential facilities, those are residential, so travel time may matter relatively less than adult day programs, but it still plays a role, for instance, to make sure that families have access to family members in close proximity. Regardless, there is a difference between residential and non-residential aspect of these services. So when we define the relevant markets for adult day programs, we use narrower geographic boundaries, in this case, defined by counties. While for ICFs and ARFs, we use regional centers, that is the catchment area of a regional center, as the relevant geographic market. The catchment area of a relevant regional center is typically multiple counties, with some exceptions. We also analyze this transaction across other geographic boundaries as sensitivities, and we don't find our results sensitive to those decisions. Once we have identified the product market and the geographic market, we move on to assessing the risk that arises due to the transaction. For our purposes here, we use DOJ, Department of Justice's, and Federal Trade Commission's merger guidelines to identify thresholds that would raise competitive concerns. By thresholds here, I mean when one looks at Department of Justice and Federal Trade Commission's merger guidelines, there are thresholds in there that define a merger as identify a merger as presumptively anti-competitive if it exceeds certain amount of combined share that the merging firms will have, and if it exceeds certain concentration thresholds. Concentration itself is measured by using what's called Herfindahl-Hirschman Index, in short HHI. Which captures, again, as I said before, both the number of providers in a market as well as their relative size. So if there are two providers in a market, let's say with 50% share each, the HHI will be just computed by squaring their share. That is squaring 50% twice and adding it, which gives you 5,000 as the HHI. And if you're using, if it's a market with 10 different players, each with 10% share, then using the same approach, HHI will be about 1,000. HHI itself goes from 0 to 10,000. Using these thresholds, we identify if the merger raises concerns in any of the relevant product and relevant geographic markets. Next slide, please. So I will now describe our results for each of the relevant product markets and geographic markets, beginning with ICF, that is intermediate care facilities. At a high level, what this map shows you is that there are a number of these facilities across the state, over 1,000. Savida and Rescare will combined control 95 of these facilities, leading to a combined share of less than 10%. which is well below the thresholds in merger guidelines. Commonly cited threshold in the merger guidelines and in litigation context is that of 30%. By computing shares for the state of California, I don't mean to imply that the entire state is the relevant geographic market. Rather, what we find is that when we evaluated the transaction in narrower markets, like counties or regional centers, we didn't find any overlap. That is to say, Savita and Rescare do not operate intermediate care facilities in the same counties or even in the same regional center. Next slide, please. When we look at adult residential facilities, as I said before, we evaluate them, the overlap between Savita and Rescare. By overlap here, all I mean is whether they are providing the same services in the same geography. We analyze their overlap across regional centers. There are 21 of these across the state, and we find that they have overlapping offerings in two areas. One is the Tri-Counties Regional Center, which includes San Luis Obispo, Santa Barbara, and Ventura counties, where there are over 150 adult residential facilities, of which Savita and Rescare will control 7 after the merger. In Los Angeles Regional Centers, which itself is a combination of several regional centers, in that area, we find there are over 1,500 adult residential facilities, and the combined firm will control about 35 of them. These numbers can then be used to calculate shares, which is what we present in the next slide. We have what we like to call donut charts, given their shape. On the left is the chart for Los Angeles County Regional Center, and on the right is Tri-Counties Regional Centers. In both of these areas, the combined firm will control less than 5% of facilities. And as I've said before, would not meet the merger guidelines thresholds. Next slide, please. And here's the third product market, adult day program. Adult day programs, which we evaluate county by county. There are 58 counties in the state of California, of which 3 of them have both Rescare and Savita providing adult day program services to individuals with intellectual and developmental disabilities. In Sacramento County, both Savita and Rescare have 1 facility each, with another 83 providers. In San Luis Obispo, Savita and Rescare have about 3 facilities, and there are 10 other providers in the county. In San Bernardino, Savita has about 15 facilities, and Rescare has 1, and there are 58 other providers of ADP services. We can now take this information and convert them into shares, which are presented on the next slide. Again, it's the same presentation format, 3 donut charts. On the left is Sacramento County. Combined share of the merged firms will be less than 2.5%. In San Bernardino, the combined share higher than in Sacramento, but still below what's often used in the merger guideline thresholds, or the number coming from merger guideline thresholds. And in San Luis Obispo, the combined firm will have about 23% of facilities. In San Luis Obispo, while the combined share is below 30%, the change in concentration, that is the change in HHI that results from the transaction, will be higher than the thresholds in the merger guidelines. That is, if one is applying, taking the thresholds from the merger guidelines and evaluating the transaction in San Luis Obispo itself, this will raise some competitive concerns. and would raise the question of further analysis to identify whether the transaction will harm consumers of adult day program services. We do find, however, that parties' facilities in this county are located about 50 minutes from each other, suggesting that the intensity of quality competition between them may be limited to begin with. We also identify whether the transaction, if evaluated in slightly broader area, which is in this case Tri-Counties Regional Center area, will raise concerns, and we find that it will not. Next slide, please. So to summarize the results of this analysis, what we find is that the transaction is not likely to reduce competition for IDD services. And that's because with respect to intermediate care facilities, there is no overlap between their service offerings. For adult residential facilities, there is minimal overlap, and the combined shares and changes in concentration do not meet merger guidelines thresholds. And with respect to adult day programs, the concern is raised only in San Luis Obispo, where parties' facilities are located far from each other, and the rates are administratively set for these services. So in terms of the direct impact on prices, there are limited to no concerns. Thus, absent significant market structure changes, we think that the increases in healthcare costs due to this transaction are unlikely. Next slide, please. I will now move on to the impact of this transaction on labor markets. Just like transactions can increase concentration, reduce competition, impact consumers of services, they can also lead to an increase in employer concentration and reduce bargaining leverage of workers, which in turn can lead to lower wages or increased unemployment. Here we are relying on empirical literature in this space that shows that wage growth slows only following those mergers that lead to substantial increases in employer concentration. And even then, it's mostly for workers whose skills are less transferable outside of the industry. In this case, as I've just shown you, this merger does not really lead to substantial increases in employer concentration or increases that would raise significant competitive concerns. Therefore, we also arrive at the conclusion that this transaction is unlikely to significantly increase employer concentration and substantially reduce competition for workers or lead to a reduction in their wages. Next slide, please. And finally, in this section, we also ask the question of whether the transaction can contribute to a trend of consolidation, right? A single transaction like the one at hand here between Savita and Rescare may not raise concerns, but if it is a part of a series of acquisitions that collectively contribute to a trend towards consolidation, that can lead to reduced competition over a longer period of time. So to analyze that competition, we evaluated combined share that the merged firm here, Savita and Rescare, have now, as well as going back in time over the last 6 to 7 years. I believe we had data going back to 2019, so a 7-year period. And the idea is, if the combined share has been rising over time, then that would suggest a pattern of increasing consolidation. To preview the results, we don't find that in any of the 3 product markets here. I'll show you those results now. Next slide, please. When we look at intermediate care facilities, you'll see that there has been a decline on these facilities over the last 7 years. There were about over 1,100 facilities in 2019. And by 2025, we have a drop of nearly 146 facilities. And the parties' combined share, however, has not increased over that time. What that means is Savita and Riskare combined had about 11% share in 2019, which is actually down by a percentage point in 2025 or by 2025, suggesting that Savita and Riskare facilities have also been closing at the same rate as overall intermediate care facility counts have been going down. Next slide, please. For adult residential facilities, we have a similar pattern. Both firms have maintained a share around 5% over time. There is no meaningful increase in their combined share over the 7-year period. Next slide, please. Same pattern for adult day programs. When we look at Sacramento County, share has been stable at around 2.4%, and in San Bernardino, around 22-23% over the 7-year period. Next slide, please. In San Luis Obispo, share has been largely stable. The increase here jumps out a little bit relative to other slides, but that's mostly because the total denominator here is quite small, of about 14 facilities. So even a change, opening or closing of one facility can make it look like a relatively bigger increase. But overall, this won't be described as a meaningful change in their combined share over time. So this analysis suggests that the transaction is not going to contribute or meaningfully contribute to a trend towards consolidation. Next slide, please. I will now switch gears and discuss our analysis of the change in ownership here and how that might raise concerns. So as I said, the transaction itself does not materially change market competition, but it does raise separate concerns related to quality and access because of the acquirer here, Savita's history and financial approach. Before I discuss those results, I'll just spend a brief amount of time on the analytical framework underlying this analysis. So as it's clear, mergers involve a change of ownership. In this transaction, Savita will assume control of Riskare. A change in ownership can result in changes to managerial incentives, changes to operational practices, changes to quality standards that the merged firm will put in place after the merger. And looking at here, Savita's past track record can inform any potential changes that may result from the change in ownership. Next slide, please. The initial review of this transaction, I think Brian discussed before, raised concerns due to Savita's quality and its public reporting. So to analyze it further, we looked at both Savita's internal quality data as well as financial data, and we compared these data, the patterns from these data against internal and external benchmarks, as well as Savita peers, a peer group. And we analyzed publicly available data. We looked at public reporting. We looked at government administrative data. We looked at quality information shared with California Department of Public Health, and how credit rating agencies have viewed this transaction more broadly. I will now switch on to the results from that analysis. Next slide, please. So we began with Savita's internal quality metrics, and what we found is that they largely show a favorable picture towards Savita. Next slide, please. Savita conducts internal client satisfaction surveys. We had data on those surveys, and we were able to compare resident response to those surveys against a California average, an external benchmark against which we could compare how Savita internally has been reporting about its own quality performance. There are several of those metrics that Savita looks at with respect to client satisfaction. On the slide here, we're presenting 3 that seem to do an overall job of looking at overall quality at Savita facilities. And these are coming from 3 different questions. 2 of them geared towards individuals, and 1 geared towards family and guardian of individuals who are at adult day programs. So when we look at the question that was asked to individuals who are consuming services at intermediate care facilities or adult residential facilities about do they like their home or where they live, we find that Savita's internal rate of 95% exceeds California average of 90%. For adult day programs, the relevant question was, do the residents like going to their day program? And again, Savita's performance of 96% exceeded California state average of about 88%. But with respect to the family or guardian questions, where these caregivers were asked whether the person's day program or job staff are respectful to the family or to the individual in question, while Savita's performance exceeds 90%, close to 91.5%, it is below the state average of 96%. However, taken together, it's still overall pastes somewhat of a favorable picture towards Savita when you're looking at Savita's internal metrics. Next slide, please. In addition to client satisfaction surveys, Savita also looks at several other metrics, such as program participation rate of individuals, chronic condition management rates, their physical requirement rates, medication errors, flu vaccination rates, rate of compliance in inspections, and rate of reports related to issues arising in these facilities, and whether those reports were made on time or not. For these performance measures, we did not have an external benchmark, and we only had access to Savita's internal benchmark. With respect to that internal benchmark, Savita meets that across all of these metrics. And while not all of them, for some of them, it has also seen an increase in its performance over time, which are for program participation rate, physical requirement rate, and vaccination and medication error based metrics. Next slide, please. However, when we look at public reporting on Savita's quality, that track record is inconsistent with Savita's internal metrics. I'll present those results next. Next slide, please. So when we looked at public reporting on Savita's quality, which this map summarizes overall, and I apologize if you cannot read the content on the map there, but what I can tell you is that Savita has a decade-long poor quality record across several states, where it has been, where complaints have shown that Savita has had issues related to resident abuse, medical mismanagement, staffing failures, failures with respect to reporting of incidents, and outcomes themselves from these complaints have ranged between administrative penalties to facility closures. The geographic spread here indicates that the performance issues are not related to a particular state or a particular regulator, but have occurred across Savita's broad national footprint, which provides context for evaluating concerns related to Savita's ownership and how if the practices that have led to these outcomes, if those practices were to extend to rest care facilities, then there would be a concern about quality and access with respect to those facilities as well. Next slide, please. We also had access to Savita's quality measures reported to with respect to intermediate care facilities. Citizens as well as facility operators can report various metrics to California Department of Public Health. And these metrics include complaints with respect to the facilities and provision of services there, deficiencies at these facilities, documented violations, any citations, and any penalties with respect to those citations. That's what this chart on the right on the slide is showing. where we compare Savita's performance on all of these metrics against both Rescare, the entity that it's going to acquire, as well as other similarly sized facilities. So for instance, if you look at the leftmost set of 3 bars, you'll look at the number of complaints, and you see that Savita had about 66 complaints per 100 ICF beds in 2024. This number is greater than both Rescare by about 22 and other facilities by about 40 for all the complaint measures. And this pattern continues whether you look at deficiencies, where Savita seems to perform worse than Rescare and other facilities, and with respect to citations and penalties associated with those citations. Overall suggesting that Savita's quality is lower than its peer group. Next slide, please. So that was the quality piece and how directly Savita's track record generates concerns with respect to Savita's ownership of Rescare facilities. We also looked at Savita's financial strategy and what that might say about the risk involved with this transaction. Next slide, please. So Savita's current owners, Centerbridge, acquired Savita back in 2019, or completed its acquisition of Savita back in 2019 with an initial investment of about $430 million. Soon after, in the March of 2019, the owners withdrew about $100 million in terms of in the form of dividends. And within a couple of years, by March 2021, the owners had extracted over $480 million from the overall entity. This practice is called dividend recapitalization because, the way these dividends have been extracted from the facility is by raising more debt. And that's sort of where the concern arises from. Because by taking on more debt to pay dividends to the owner, not only increases leverage that the firm has, it increases the financial risk associated with the transaction. It reduces cash that may be available for investment in operations, staffing, facilities, and so on. And it can also limit flexibility during weaker economic environments by reducing the financial cushion that the merged firm or that Savita has, or in this case, if those practices were extended, the merged firm may have after the transaction. So certainly indicates an aggressive financial strategy, something that is also highlighted by independent credit reporting agencies. Next slide, please. So credit rating, here we have some quotes from the credit reporting agencies. For instance, Moody's described Savita's practice as particularly aggressive. Specifically, Moody's described that when an acquiring firm pays within about a year after its buyout, pays about 75% of its own initial investment in the deal to the owners, that strategy can be particularly aggressive. In this case, Savita's dividend payments approximated about 113% of owners' initial investments. S&P Global also highlighted that Savita is expected to remain highly leveraged. Here it just means high debt relative to earnings over the next several years, thus suggesting both concerns about financially aggressive practices and any possible fallout or risk that may come from those practices. Next slide, please. This chart is sort of presenting another take on the same concerns. What we did here is we looked at Savita's leverage, which is defined as its debt relative to its earnings over a long period from 2019 to 2025. And we compared that leverage to its peer group, both median leverage that the peer group had and the average leverage across the peer group. So when you look at 2019, Savita's financial leverage ratio depicted by that red bar was about 4.7 or so, suggesting Savita's debt was about 5 times its earnings, but it was lower than its peer group. Soon after the acquisition by its current owners, it rose in 2020 moderately to about 5. And after dividend recapitalization in 2021, it almost doubled to 8.7, suggesting 9 times debt that's 9 times the earnings. And that high leverage continues to date. In September 2025, it was lower than 2021, but still relatively higher than its pre-acquisition by Centerbridge in 2019, as well as higher than its peer group, suggesting Savita carries more financial risk than its peers. Next slide, please. And that brings to the bottom line conclusion of this section, that the poor track record increases both risk of reduced quality and access to IDD services. Savita has performed worse than its peers across a variety of quality and financial metrics, which raises the risk if these practices were to carry over to the combined entity. And Savita's financial risk measures, while they have improved in recent years, they're still elevated relative to the peers, which can impact its ability to invest in quality, its ability to withstand economic conditions, downturn in economic conditions, and in an extreme scenario could also lead to facility closures. Thank you.
Thank you very much. And since that was a very comprehensive presentation with various sections, I just want to point people back to slide 18 that had the key takeaways and summary. Questions or comments from the board?
First off, I want to appreciate and really respect the approach this analysis took, and in pretty short order, especially going above and beyond the narrow market competition analysis. I had 2 questions about process here. I understand that our job, or the office's job here, is complete at the point we hand this report off to the AG. I don't pretend to understand what scope of authority the AG has exactly, but I know it's limited. But we're now on notice that because of Centerbridge and Savita practices, there's a real risk to quality and access. I presume that this report will go to other relevant offices or agencies and regulators. Is there thought about bringing back a report down the road about whether and how they're able to apply enhanced scrutiny to make sure those outcomes don't happen to the extent that they can, or to monitor it?
So this is really the end of the story for us. The regulations kind of contemplate the preliminary and final report. And as you referenced in our statute, it does say that we may refer our findings and investigative file to the Attorney General for further investigation. But in terms of follow-up reporting, there's nothing really in our current statute or regulations that would allow us to sort of revisit this, unless the director ordered the office to do a study that may include this transaction or on this transaction. That's a possibility. We could see, what's happened since our review concluded, but really our job, as defined in the statute and regulations, pretty much ends at the point at which we release the final report.
I do want to note this was a somewhat unusual transaction to have be our first cost of market impact review. And because there are so many sibling departments within state government that have a role with these facilities, we did coordinate with CDPH, with DHCS, with DDS, DSS. So yeah, there are a lot of facilities. So, they obviously have a very important oversight role. I think it was important for us to hear their perspective, and they'll have a very important role moving forward.
If I may, just one other quick question. I gather there was only one public comment when I was looking on the CMIR website. I didn't notice that. Is that being made public at any point? Or?
We're not posting the public comments. They are public documents, so they are available if through a PRA, but as of right now, we have not decided to post them.
Just, in other proceedings like land use and so forth, when there's a process like this, like often that public comment is posted publicly along with the material, so you can weigh what the final report looks like compared to those. I'd encourage you to consider that.
It is definitely something that we'll consider. We're also kind of balancing the fact that patients can submit us public comments as well, and we're trying to honor, their privacy to the extent that's possible. But this is our first one. It's certainly something we can consider for future reports.
Just also point on that point of comments, right, to the point of the number of data that's being utilized here. Some of this information is part of public record, transparency reports related to some substantiated violations, those kinds of things. So just want to, we can figure out ways, I know there's source kind of information on each of the data components, but want to make sure that that's known for folks as well. Richard.
Thank you. I know that perhaps some of us may feel some frustration that we can't do anything more, but I guess I would note that first of all, I assume that I appreciate the in-depth presentation, that there will be a formal report that will be available to the public and also to the other agencies as a result of this work, correct?
It's on our website.
It's on the website. Good. So because, frankly, we're the Office of Healthcare Affordability, and while we have this charge to look at consolidation, it is on the quality end. It is the responsibility of other agencies who have already been tasked with this to follow through and monitor. And so hopefully the sunshine that we've been able to light on this transaction will also alert the other agencies to pay attention what happened, to what might result from this merger as well. And so, I do appreciate the fact that we're able to learn about it and have this information presented publicly. I guess the other question is that I appreciate this is our first one. I don't know how many more are maybe coming down the line. I know this was a bit of a discussion when we put out the regulations, obviously, and I think it's worth spending the time going a bit in depth in this one. How do you see future ones being presented to the board as well?
We've really talked about that. It seems like these presentations are warranted to sort of talk about maybe the key findings. Maybe in future presentations, we don't go as much into detail about the analytical framework, but we'll definitely need to focus on quality concerns. If there's a market concentration issue, we'd like the board to know about that.
Yeah, and I think we would welcome board input about what you would like to see, because yes, this one did go into a lot of depth, and I think it's important for folks to see it's not necessarily a simple matter to just define we did look at regional, what is the right region, multiple types of facilities were involved here. So open your feedback about what you'd like moving forward.
Okay, that's helpful. I'm just thinking about what sort of structure that also helps facilitate the board doing whatever is appropriate as a result of these. I'm sure we want to be informed. Just conscious also, again, depending on how many come down the line, exactly how much time the board may spend with each individual case. But I also, I think that this was very helpful to actually look at this being the first in-depth case to go into this depth, and appreciate the work that was done and also the information was presented. Thank you.
And our next item will go through and talk about other transactions, so you'll get a sense of that shortly.
Yeah, I want to add my appreciation. I thought the review was very thorough and very methodologically sound and helpful for transparency purposes. I guess the question I have is, of the agencies that are listed and that presumably will get this final report, do any of them actually have any authority to intervene in this? And if so, who are they, and what might be the timeline for that?
Yeah, appreciate the presentation very much to give some of the acronyms and what's an adult residential facility, intermediate care facility, all those components, which is why there's so many different departments engaged in this particular effort. Slightly different purviews in terms of whether we're talking about licensing for kind of general health and safety of the environment. Social services would be for adult residential facilities, for example, and that's where you see, I was looking very carefully at how you were defining quality, right? Because some of that was being defined by substantiated complaints, other components, you're seeing kind of internal metrics, you're seeing some that might come from some of the other departments. So long story short, each of the facility types has different, depending on what facility type it is, will have a different department engaged and maybe differently depending upon, again, the setting type, what they're looking for. But that is how I saw that the consultants here kind of define that. And if you look at some of the sourcing pieces, that's where the data source is for things like substantiated complaints and et cetera. So long way to say the information that we just heard is informed by the departments, right, and their current oversight authority. That's kind of how it was compiled in some cases, but it's also then to the point of having more transparency, a way to say, okay, now we know this is also a proposed merger, and how are we thinking about the potential impacts and change of what's being seen as well. So public report posted. And I think that's another kind of newer piece about how we're then coordinating across departments, given this new transparency component. Anything to add or correct there?
I would just reiterate what Director Landsberg said, is that this was a very interactive process, especially when we had our initial draft. We coordinated with all the agencies that were listed on one of the earlier slides and got their input on the report. They offered some technical changes. So I imagine in future reports where other agencies are implicated, we'll be working with them as well before we release a preliminary and then final report.
To follow up on Sandra's question, is there any agency that can say, no, this merger can't happen? Can the AG say that? Can any part of DHCS or?
The agency would, the AG would have that authority depending on what kind of concentration or anti-competitive impacts this transaction would have. As far as the other health agencies that are involved, I'm not sure to what extent they can actually put a stop to this.
And does the AG have the authority to say this not based on anti-competitiveness, but based on concerns about quality?
I don't think so. And I'm going back to our statute, which really contemplates referral to the AG to look at anti-competitive impacts. So I'm not sure. I can't necessarily comment on whether they can intervene based on quality issues.
And two other comments. One, I add my appreciation for the thoroughness of this report. I did find the focus on competition a little odd in this context, in that my understanding is that, virtually all of the revenue from ICFs comes from Medi-Cal, and I don't know the kind of rate setting for ICFs in detail, but I imagine it's that there's not a concern about effect on prices, because Medi-Cal sets prices, and so that even if this were highly concentrated, that prices probably wouldn't go up. And this may be a one-off, and maybe future CMARs will be looking at hospitals and other entities where prices matter more. But I found it a little hard to understand what the connection would be between concentration and prices for this set of facilities. And maybe I misunderstand how prices are set for ICFs.
Yeah, it looks like Nitin wants to address that question.
Yeah. Thank you for the question. I'm sorry, the screen, at least on my end, I cannot really tell who's asking the question because of the distance. But the way I would describe this is that the reason the competition angle is relevant is because competition impacts not just, or competition doesn't just mean impact on prices. That is, the firms across industries are not only competing on basis of prices, especially in healthcare, where there is often consumers don't even see prices, right? Their impact is indirect, because if you're looking at a hospital transaction, for instance, consumers may be paying a smaller copay and not really making their choice based on hospital's price in many instances. Similarly here, I agree that Medicaid is DHCS has a lot of authority here to regulate prices, and these prices are regulated by Medicaid fee-for-service rates as well, which impacts the merged firms' ability to raise prices because of any increase in bargaining power. However, to the extent merged for these providers in a hypothetical transaction, if you have several providers that are located close to each other and compete based on quality or based on other features, services that they offer that go into the decision making of individuals and their families, then those measures can be impacted because of reduction in competition as well. So while in the presentation I didn't get a lot of time to get into that detail, but the way the question was asked is, does the transaction lead to a reduction in competition? If it does lead to a reduction in competition, then we already have concerns about outcomes that consumers care about. Can it impact prices? Let's say it cannot because prices are regulated, but can it reduce quality? For sure. If it's a reduction in competition, it can impact incentives of providers to compete on quality. So in this case, our quality concerns are not coming from a reduction in competition. They're coming from more of Savita being the acquirer here. Please let me know if that answers your question, or more detail will be useful.
I appreciate it, and it's helpful. And again, maybe one-off because other transactions that we look at won't be so heavily Medi-Cal dominated. On the Medi-Cal side, I also wonder what the competition for patients looks like, and whether whether people with intellectual and developmental disabilities and their families have much choice as they're looking across facilities. But I appreciate the answer. Yeah, thanks.
And apologies for not mentioning this before. This transaction was also reviewed by the Federal Trade Commission, which, and that can, once you recall the map that I showed for Savita and Rescare, that indicates why Federal Trade Commission reviewed this transaction. And they also recognized Medicaid regulating the prices here, but they asked the parties to divest for ICFs in certain parts of the country where both Savita and Rescare compete on those services. So that's some additional information just for context.
I want to acknowledge that Board Member Don Molds joined during this agenda item and also give you the floor. You had a question?
Thanks. I was actually going exactly where Rick was going. I was trying to understand better the quality piece, and I had understood this process as feeding the Attorney General's review of competitive dynamics, and just I'm wondering about whether or not there's anything actionable in the quality observations, or it's just an exercise in sunshine. And I think we got the answer.
Okay, not seeing any additional questions from the board. We will open this item up for public comment.
We'll now take public comment on this agenda item. Please raise your hand or step to the podium. Please limit your comments to 2 minutes so we can hear from everyone. Seeing no hands raised, we will start with the individual at the podium.
Beth Capel for Health Access, and it was certainly a thorough review of the study, and we apologize for not submitting formal comments. A couple of key points in response in part to the board discussion and also to the materials that were presented. So it's very good that the other departments were involved. My experience is mostly on the hospital and nursing home side. I can tell you on that side, the department has the authority to refuse to grant a new license. And that is something that does happen. I'm not less familiar on the ICF, DD, and the adult day program, what the authority of those departments are. But that's existing law and has been longstanding law. Taking a license away because of the due process property right inherent in a license is a very hard thing to do. But the ability of an agency to refuse to grant a license when there's substantial quality questions should be an area of focus given these concerns. Second, many licensing agencies know very well who their problem children are and keep a list of them. Everybody who deals with nursing homes had their own personal list of problem operators that we all knew about, and that somehow kept working in the business. So that would be, so transactions like this raise those questions. It may not be the simple referral to the Attorney General for antitrust, but it is an important piece of the state's oversight of these entities. Second, we have seen in the past abuse of the Medicare program, also one with rate setting, by hospitals after mergers where they either leading to, I'm thinking of Reading and Red Bluff, leading to very substantial allegations of Medicare fraud. So this kind of leveraging raises those questions. They are the questions we've had all along about the presence of private equity in the healthcare space. And we also want to acknowledge that private equity can be problematic on the way in the door. It's also problematic on the way out the door when they're trying to extract the returns that they anticipated and may or may not have achieved. So all laws that are as important as this one are works in progress, and maybe someday we'll have the ability to look down the road and update. Finally, we would note, and this, we apologize for not having commented on this before, but this is going to be important for all sorts of transactions. There are different levels of care for an ICF or an adult day program. And so to look at concentration simply by licensing category, that would be like saying the trauma center, the top level trauma center is the same as a standby emergency room. It's not. And so we think that it's really important to do that next. It would have been 5 more slides. So, I'm just happy not to have seen it today. But seriously, you could have an operator who saw a market niche, who decided to do all the low acuity stuff or all the high acuity stuff, and to make money that way. That's the sort of thing we've worried about, and that is part of the reason why we wanted this authority to exist. Thank you.
Thank you. Looking virtually, seeing no hands raised, we'll give it just a moment. To the room, please step to the podium. All right, seeing no hands raised, no one at the podium, that concludes public comment on this item.
Actually, I just had a question for the analysts, if they're still on or not. I don't know if they leave.
Yes, right here.
Oh, hi. So I know you looked at facilities. Facilities come in different sizes. Was it narrow? I mean, are they, so in terms of your market share? I mean, so I'm just curious as to why facilities versus, let's say, percentage of beds or whatever the equivalent unit is. So sorry, I should have asked that earlier.
No, that's a great question. And that was the starting point. That is us looking for that information. But we were limited by the extent of data available for what I would call the denominator here. That is parties other than the ones that are part of the transaction, that is other than Savita and Rescare. We had limited information on their bed sizes and additional information that you would generally use for looking at shares of these facilities. One thing, however, that did limit some concern is that many of these facilities tend to have, for instance, we looked at ICFs, and we know we had bed sizes there for ICFs, intermediate care facilities, and their facilities tended to be smaller than many others, which means that the share as a percentage of bed sizes, number of beds would be smaller than what we are computing already. We couldn't do the same thing for ARFs, adult residential facilities and adult day programs, but they do also tend to be relatively homogeneous in size. So that changes the impact that that calculation would have to, or at least minimized our concerns about not having that metric. But yes, in the ideal world, one would like to account for acuity or severity of conditions, run it different ways in terms of number of beds and number of residents and so on. But we didn't have all of that additional information available either.
All right. That's very helpful. I mean, perhaps some sampling just to determine like homogeneity, right? If it is fairly homogeneous, less of an issue. Obviously, there's a large variation, which hopefully there's some data, like someone's licensed for 300 beds and someone's licensed for 10, right? Then, and someone's buying out all the 300s, then that might be a little different, but okay, thank you.
Just also want to quickly, just for awareness and education, as it relates to oversight, or for public knowledge, some of that oversight is built in. So if there are more substantiated complaints of a particular setting, that does mean those settings are likely to see more from licensing entities, oversight entities intentionally to do more oversight. So just want to say that is a also built in and embedded into our processes and accountability. Given that additional conversation from the board, we are going to reopen public comment just to make sure there's no additional public comment on this item.
All right, please step to the podium or raise your hand. Noting for the record, we have about 75 virtual attendees. Seeing no hands raised and no one at the podium, that concludes public comment.
Thank you. We are going to move on to item 4B. This is the update on cost and market impact review program. We'll welcome Assistant Chief Counsel Heather Hoganson for this item.
Good morning. I'm Heather Klein Hoganson. I'm the other Assistant Chief Counsel for OCA's Compliance Unit. I go by she, her pronouns. So our last update was in November 2025, and as you've probably previewed in the slides, we've gone through a number of transactions since then. We want to go to the next slide. It's our 2-year anniversary. We officially began reviewing transactions April 1, 2024. And so in the first year, we reviewed 14 transactions. And then from April 1, 2025 to March 31st, 2026, we had 31 transactions. So we've done 45 total transactions, and many of those transactions had more than one submitter. We're anticipating that with the passage of AB 1415 last summer, those numbers will go up. The average time between those that we have waived, going to CMIR on, from when they were deemed complete by our office has been about 26 workdays. I know that that was a concern by the board when we were discussing the regulations at first, so just want to let you know that about a month if we're waiving it. Just want to go to the next slide. So over the 2-year period, we've looked at a number of skilled nursing facilities. We've looked at a few labs, physician organizations, et cetera, et cetera. So we do have quite a bit of variety in what we've been looking at. And again, with the passage of AB 1415, we're going to be also looking more at MSOs, private equity hedge funds, and entities created solely for purposes of the transaction. So we're going to the next slide. So that was the 2-year overview. Since November at our last presentation, we have had 14 different filing parties for 9 transactions that we have commenced. And we have completed 14 transaction reviews by waiving them from November to now, including the one CMIR that you've just heard about. We've also had about 7 pre-filing meetings generally with law firms who are representing these clients, whether or not they have to file, issues of confidentiality and things that come up before they file. So when requested, we engage in these with law firms as best we can. Next slide. Okay. I don't really need to go over this slide, but we've completed the ResCare. And all of that information is posted on our website. Next slide. So some other transaction reviews we've completed since November 25. We had Resolute, which we waived Christmas Eve. Resolute owns outpatient imaging centers in 6 states, including California, looking at Los Angeles, Orange, and San Bernardino counties. They were selling to Envision, which is diagnostic imaging centers in 5 other states. This was Envision's first entry into California. So Envision acquired 5 outpatient imaging centers and 2 MSOs. The next one was Med Impact. They acquired SaveRx. This was OCA's first PBM transaction. So in California, SaveRx business is limited to a small number of self-insured ERISA plan clients. After the transaction, Med Impact will operate SaveRx as a subsidiary. Now, while there are 3 main PBMs in the national market, of course, CVS Caremark, Express Scripts, and OptumRx, this is a consolidation within the independent PBM market, which could down the line result in a future contender to those big 3. The next one on the list is CCW La Jolla and Classic Residence Management Limited Partnership. These are the V communities of San Diego and Palo Alto. Large senior communities. They both hold skilled nursing facility licenses within their communities. And it's part of a national deal with Life Care Services, which owns 136 senior living facilities throughout the United States, including 6 continuing care retirement communities in California. That was waived in December as well. Next slide. Then Evolent Health, which we waived back in November. They're a third-party administrator to health plans with minimal presence in California. Privia is a holding company that collaborates with health plans and health systems through MSOs or ACOs. And in this transaction, Privia was purchasing all the shares of Evolent's ACO business. Then we have the next one is El Centro Regional Medical Center, the city of El Centro, and Imperial Valley Healthcare District. We waived this one mid-December. And for whatever reason, there's a lot of San Diego in the last few months. So you'll see that a few times. So based on some financial insecurity in the area, AB 918 of 2023 created a single healthcare district, the Imperial Valley Healthcare District, to consolidate healthcare services in the region. IVHD operates a general acute care hospital, a skilled nursing facility, and outpatient centers in Imperial County. The city-owned El Centro RMC was 161 beds, the only other general acute care hospital in Imperial County, and it has been struggling. UC San Diego will oversee operations under a 5-year joint powers and affiliation agreement, and UC San Diego had already been asked to oversee El Centro RMC back in 2016. The healthcare district is governed by a board of directors that includes the prior now dissolved healthcare districts, which was Pioneers Memorial and Hefferman Memorial, as well as local and tribal governments. And this consolidation may allow the new district to obtain enhanced Medicare payments under a single license using the sole community hospital with the federal government. And the last one on this slide is Ambulatory Topco, which was waived in November. Ascension Health Alliance, which is a nonprofit Catholic health system not currently operating in California, was acquiring Ambulatory Topco's subsidiaries, including AmSurge. AmSurge operates 250 ambulatory surgery centers, across 34 states, with 25 of its ASCs in California. And next slide. Care Meridian was waived January 16th. In this transaction, Sierra Summit Head Injury Care Homes is an adult residential rehabilitation service provider located up the road in Rockland, Placer County. It is not a healthcare entity under OCA's rules, but Care Meridian is a healthcare entity and therefore filed this notice of acquisition. We'll note Care Meridian is a subsidiary of National Mentor Holdings, which also includes Savita, but is itself separate from Savita. So to distance itself this from the transaction we just heard about. And then Physicians Health Network Medical Corporation was also with that same day, January 16th. With the retirement of some physicians in a professional corporation, Physicians Health Network is transferring their independent physician association ownership to David Ulick, MD, and Eva Vargas, RN. The IPA is comprised of approximately 40 primary care physicians with an extended network of over 500 specialist physicians and serves Medi-Cal patients in San Bernardino and Riverside counties. And it contracts with the Inland Empire Health Plan. And then next slide. So Imperial Care Skilled Nursing Facility and El Centro Regional Medical Center. This was waived early in February. The 123-bed skilled nursing facility was transferring to the El Central Municipal Hospital and the aforementioned Imperial Valley Healthcare District. Imperial Care is one of 3 skilled nursing facilities in Imperial County. And then the next one on this slide is Abbott Laboratories and Exact Sciences Corporation. This was waived in March. Abbott is headquartered in Illinois and is a global leader in chronic disease management. Exact Sciences is headquartered in Wisconsin and focuses on oncology diagnostic products such as Cologuard. Abbott is acquiring Exact Sciences via a merger, allowing Abbott to enter the oncology diagnostics market. Both companies have large research teams in Redwood City and in San Diego. On this one, there was also a Hart-Scott-Rodino filing with the federal government, and there was no action by the FTC or the Department of Justice. And the next slide. Another San Diego. UC San Diego Health and the Palomar Joint Powers Authority formation. The JPA formation was waived March 24th of this year. So Palomar Health is a public health district operating Palomar Medical Center Poway, which has 107 beds, and Palomar Medical Center Escondido, which is 318 beds in North San Diego County. Due to Palomar Health's worsening financial situation, parties agreed to form a 7-year joint powers authority, which will include UC San Diego and Palomar board seats. Each hospital will have a new individual license. Certain NICU beds will transfer to Rady's Children's Hospital in San Diego, but the parties do hope to expand the region's cancer center, women's health services, and cardiovascular services. OCA did confirm with the parties that the JPA does not intend to index pricing to academic levels, but would benchmark to community market rates. And on this one, and you can see it on our website, OCA published a supplement to the online notice with further details of the transaction. And then the next one on this slide is Inform Diagnostics and Fulgent Therapeutics, which was waived February 23rd. Inform Diagnostics is a national clinical laboratory headquartered in Texas and operating 3 locations in Southern California, Anaheim, Oceanside, and Palm Desert. They serve Los Angeles, Orange, Riverside, San Bernardino, San Diego, San Luis Obispo, Santa Barbara, and Ventura counties. Its parent company, Fulgent Genetics, provides clinical laboratory services nationwide, but is headquartered in Los Angeles and serves LA and Orange County. Inform Diagnostics will acquire equity and assets from Baco Pathology, LLP, also nationwide, who will provide anatomic and clinical pathology services. The subsidiaries being acquired include a lab in Massachusetts and Georgia. And while Baco does not have lab operations in California, it does accept specimens remotely, which is about 5% of its operations. And then the next slide, Vitalant and San Diego Blood Bank. This was waived April 3rd. Nonprofit Vitalant operates 32 facilities in California for blood-related services, all north of Ventura County. And nonprofit San Diego Blood Bank has 10 donation centers in Southern California. Vitalant already was contracting with the San Diego Blood Bank to provide Kaiser with blood-related services in San Diego County. And the San Diego Blood Bank will operate as Vitalant's wholly owned subsidiary at the close of the transaction. And then finally, on the transactions completed since 2025 of November, is Sharp Healthcare and the Tri-City Healthcare District, which was just waived April 13th. Again, San Diego. Tri-City Healthcare District owns, operates, and does business as Tri-City Medical Center, a 386-bed acute care hospital serving North San Diego County, primarily the cities of Oceanside, Carlsbad, and Vista. Tri-City also operates primary care and specialty outpatient clinics in the area. Sharp is an integrated healthcare delivery system operating for acute care hospitals, clinics, skilled nursing facilities, etc. As of September 2025, it operated 2,230 licensed beds. Sharp also provides healthcare services through Sharp Reesteely and Sharp Care, operating 17 multi-specialty clinics throughout San Diego County. Under the 30-year agreement, Sharp will operate Tri-City, investing in North San Diego County. Sharp has committed to reopening Tri-City's closed service lines. And Tri-City's Healthcare District's Board of Directors will transition to a community oversight function, remaining accountable to residents. And this transaction is subject to voter approval in the June 2026 local election. And then next slide. So we still have the Covenant Care CMIR in review, and you've heard about that one before, so I won't go into any detail on that, but that's still ongoing. And next slide. Currently in review, Euclid Endoscopy Center and AmSurge. Euclid Endoscopy Center owns and operates 2 endoscopy ambulatory surgery centers in San Diego. Both ASCs specialize in outpatient gastrointestinal services. AmSurge, which we've mentioned previously, operates 250 ambulatory surgery centers across 34 states, with 25 of its ASCs in California. For this transaction, AmSurge would increase its presence in San Diego from 2 to 4 ambulatory surgery centers. And then the next one, next slide. Centene Corporation and Magellan. This is a divestment from Centene, a publicly traded managed care company. Magellan is a national specialty healthcare company focused on psychological services, pharmacy services, and specialty populations. Centene acquired Magellan in 2022 for $2.2 billion. Centene now proposes to divest certain Magellan entities listed on the slide, including employee assistance plans in California, an MSO for a telehealth provider group, and a life insurance company, which no longer has active business in California. Madison Health Group was incorporated specifically for this transaction. Madison will acquire 100% of the Magellan entity's common stock. And this matter was a referral from the Department of Managed Healthcare pursuant to the authority in our act. OCA has also received 8 submissions for 2 new transactions since starting this slide, which we are still reviewing for completeness, and they will be posted online once deemed complete. Additionally, OCA has started to receive written notices pursuant to AB 1415 passed last year for transactions by private equity, hedge funds, MSOs, and newly created entities. So those are the transactions we've been working on. Any questions on any of them?
Thank you. A lot more transactions in this second year, so appreciating the additions there.
Yes. First of all, thank you for the presentation. My guess is that when we started this, there are probably some people who hurried the transactions along so that to avoid having to do this process. So I'm not surprised that we have an increase in the second year because those transactions, they probably couldn't have. Anyway, we probably, there might have been some behavior that left to that. So I appreciate the presentation. I guess and the other thing I make note is that just sort of glancing at, again, your review, looks like for all the CMIRs that are waived, essentially that decision was made approximately, within 2 months of the initial submission. I guess the question I have here is you know, we heard the presentation on ResCare, but I also note that the submission was in April 21st, 2025, and it was completed April 8th, 2026, which is 50 weeks later, or almost a year later. And I realize these are complex transactions, did anticipate timeline? Because I assume that their merger couldn't move forward until this was complete, right? So this is a 50-week, you know, process apparently. I don't know what in terms of the other transactions that are pending, how long those will take. I think one of them you made note was actually submitted. I think let's see, where was that? April 24th, 2025. It's now April 2026. So that's still in CMI review. I guess that's one for Covenant Care. So you just speak to the length of the CMIR process and what we're, you know, how that might be impacting things and what we're trying to do to, again, recognizing their complex transactions to, you know, facilitate their completion in a timely manner. Let's put it that way.
Absolutely. So first to the first part of your comment, yes, our understanding is there were a lot of deals closed in February and March before our statute took effect. There was a lot of overtime hours billed by many law firms. In terms of the packages that we've reviewed, I said that it was an average of 26 working days that we had them open. There are time lags when we request further information from one of the parties.
Okay.
And what we do is we toll. We stop the clock. We stop our 45-day clock until they get us that information, because otherwise they could just run our time out. And this isn't basketball. In terms of, so we've only commenced 2 CMIRs, Covenant Care and ResCare. And in both cases, there are times when the clock gets stopped because we need information from the parties and we have to receive it.
Okay.
And so that's the regulations provide us with a 45-day clock if we are waiving and a 60-day clock if we are going to CMIR. But within that time, and what we will do is on our website, we have a list of all the notices with all the parties listed. And if you open up one of those notices, it will show you the 45 and the 60-day time. If we have told that because we are waiting for something, there will show a strikeout with told on it.
Okay. I appreciate the explanation. I did not have a chance to review the website before today's meeting, just look at their slides. So I think that's an important message to convey, as I'm sure as people look at how long the process takes. Certainly, if we're waiting for information, that's the ball's in their court now, and if it's taking a long time, then they're the ones who are taking the time to do that. So I think it's important to be able, and I appreciate that's on the website, so you have to take a look over there. But I think it's important that we communicate that to anyone who says, well, why is it taking so long? It's like, well, because actually it's not us, we're waiting for stuff. So appreciate it. Thank you.
Dr. Pan, for the transaction you mentioned for ResCare for April of 2025, yeah. You want to clarify the tolling?
Yeah. So specifically for ResCare, you heard Nitin mention that there was an ongoing FTC review. So when we have separate federal or state agencies doing their review, we'll likely toll the transaction pending the outcome of those reviews if their conclusions would really impact how we view the transaction. So that provides you with some context for ResCare and the time between when we received it and when we released our final report. And also, as Heather mentioned, there was various points where we had to request additional information from the parties.
Ian.
Thank you, Heather. You know, one of the organizations, Dr. Pan, I don't know if this is what he had in mind when alluded to that went on a buying spree in the hours before CMIR started, as you see, and I found myself looking at the supplemental filing, and which says they're going to raise prices, and it wasn't clear to me what indexing to a community benchmark meant, but it left me wondering why in that case the transaction was waived, and similarly to the rest. I don't know. I'm not asking to go line by line with every transaction and talk about explain the logic of the waiver for each today, but I would find it helpful if, especially on the website, if there were an explanation as to what the logic of the waiver was. Is that something you've put thought into, or?
We have put a lot of thought into that, actually. Like, how much do we want to put out there? How much is based on some confidential information we've received that might end up be confusing to the public? In this case, we did publish the supplemental on Palomar, is the one I believe you were referencing. We did publish supplemental information that we thought would be helpful in the spirit of transparency. There is a concern with the Palomar transaction specifically that prices could be elevated because UC San Diego was getting involved, and it might be academic pricing. And the supplemental filing, their assertion was that, no, we're going to keep this at community market rates in terms of other hospitals that are not academic priced. When we waive a CMIR, it's based on the fact that our regulations have a number of factors for when we will go to CMIR. And if those factors aren't triggered, then we would waive. And so that's, generally we don't see a palpable risk in terms of market concentration, quality, access. You saw in the Savita one, we had a concern about access, quality, so we went to CMIR on that one. In Covenant Care, there was a market concentration issue, and those were listed on the determinations to proceed to CMIR that we publish on those pages. When we do commence a CMIR, we have a separate web page with all the documents that are public, including our determination. So far, we haven't done that for waivers for a variety of reasons, but it's something that we can always reconsider as we get more experience and have had a bigger base. Yes.
Any additional questions or comments from the board? We'll open it up for public comment on this item.
Please step to the podium or raise your hand. Please limit your comments to this agenda item and to 2 minutes. Seeing no virtual hands raised, we'll start at the podium.
Please go ahead.
Oh, sorry. To make sure that if there was somebody online, I wasn't stepping ahead. Beth Capel, Health Access. I think most of us remember that the prediction was that there would be thousands of transactions and the system would be overwhelmed. There are dozens. It is, I do believe that a number of transactions closed, but I doubt it was thousands. Maybe there were thousands, but not the thresholds that are in the regulation. So I think just reflecting back, we have questions about the volume of waivers, and having some sort of even summary indication that the determination was made that there's not a significant market impact or something like that would probably be helpful as this process proceeds, in order to guide everyone who's paying attention to it, including those engaged in transactions, as well as those of us who are eagerly watching mergers, and some of us who have worked on hospital mergers going back to 1991, when Sharp attempted to undervalue its assets and sell out the whole thing. And Attorney General Lundgren, a Republican, intervened to prevent that. Some of us have been watching mergers a long time. The other point we would make is that with respect to UC and the district hospitals, a joint powers authority has less public accountability than either of the constituent elements. And we take that very seriously. And district hospitals are public agencies. The University of California is a public agency. A joint powers authority, if I recall correctly, is not subject to the Brown Act. And so that is a transaction that for us it essentially takes private to public entities, and the price implications are important. The transition from public entities to private ones is also very troubling. And so since you are the agency that has some authority in this area, we would encourage you to think through those implications. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Yeah, Brad Schmidt again, Northern California. I had a question on CMAR. Does organic growth trigger scrutiny for example? So say a hospital system, there's a hospital system in town here that has $2 billion earmarked for expansion. Does that trigger CMAR? So if they expand in certain markets and take over payer rates, is that part of the CMAR review process?
So I'll just remind, for public comment, we can accept public comment.
Okay, but as a
yeah.
public comment, so just hypothetically in the future, if
Absolutely.
it's possible to review expansion of health systems, because if they're not acquiring and they're naturally expanding, I think it wouldn't naturally trigger CMAR. And the other thing is, on another comment is on, when someone expands, let's say it's a nonprofit, I'm more in favor of for-profit versus nonprofit, because if it's nonprofit, there's no revenue or tax revenue coming to a city. So Sacramento has a $70 million shortfall. A lot of that is because there's no property taxes paid in the city they operate in. So it's just an opportunity to support the cities with maybe some oversight on CMAR and organic expansion. Thank you.
Thank you. All right, looking virtually, seeing no hands raised, back to the room, seeing no one at the podium. That concludes public comment on this item.
Thank you very much. We'll keep you here, Heather, for our next item, item 4C. This is the spending target data submission enforcement, introduction to regulatory text.
All right. So switching gears from the transactions to monitoring data. You may remember that the board approved in November 2025 the scope and range for penalties for the non-submission of data. So just as a refresher and context for everyone, payers register every end of May. They can start submitting their data, and the due date is effectively the first day of September. The office then gets that time to review the data so that we can publish our reports. And so we absolutely need the data for the reports. We also will be using the data eventually for enforcement. So of course, we want to make sure we get the data timely, and we want to make sure it's correct. And with possible enforcement looming, it has been brought up during comment periods before that someone could just not turn in data as a way to not get dinged for exceeding the spending target. So therefore, the board in November, and the scope and range was discussed in July, August, and September before this motion, to have an administrative penalty of $10,000 if they don't submit by September 1st. An additional administrative penalty if they don't submit $50,000 for non-submission of data by November 1st. And then an additional administrative penalty of up to a base amount of $5 per member per covered life if data is not submitted by December 1st of the submission year, which would go to $10 by December 31st of that year. And then the per member base penalty amount would double for each consecutive year that the data was not submitted timely. We go to the next slide. Kind of takes us to our cycle of life for penalties. The penalties would, especially the per covered life penalties, would be in consultation also with other regulators such as DMHC or CDI, so that we're not impacting tangible net equity or financial solvency of a business. And next slide. So that brings us to today. And last week, we published online our draft text, a proposed emergency regulation text under the Act's Emergency Regulatory Authority. And that comment period is going to be from April 20th to May 11th. And so the draft is online. We encourage everyone to take a look at it, and we will be accepting informal comment periods. We will bring those comments back in summary fashion for the board. Specifically as to the text, in addition to that scope and range, OCA has added a definition for accurate complete because it's important not only that the data is submitted, but it's the correct data. And so we've defined that in regulation. We've added an extension process. OCA does understand that situations occur, and based on stakeholder requests, have provided an additional window for submission on request. This window includes regular communication and updates to OCA as to what the data, when the data will be fully submitted. We've also recognized stakeholder feedback that implementing new data requests involve operational issues, and especially with the new data submission guide that, as Vishal mentioned earlier, was approved on Monday by the Office of Administrative Law. There are some new technical pulls that are going to happen with plans and payers. And so balanced with OCA's need for the data and allowance for the new files gives some training room without penalty for the newest files requested with that passage, just in case a mistake happens or it's not complete. If it's just for those new files, that per member per life fee won't be as onerous. We've also included in the proposed text due process and timelines. And so if someone says they submitted it and we say they didn't, and there's an actual dispute, it would go to the Office of Administrative Hearings, which is the central panel of disputes for California, and an administrative law judge would make that finding to determine the penalty. Any questions on, well, I guess the next steps, if we want to go to the next slide. So we have our informal comment period, as I mentioned, and that we will bring comments back to the next board meeting. The next steps after that would be to prepare and submit the regulations to OAL with any updates and changes as we've gotten from comments. And as I mentioned, September 1st, 2026 is the data submission due date. So with that, are there any questions on data submission?
Thank you very much. And we do look forward to hearing the public's comments on these at our next meeting. Questions or comments from board members? Seeing none, we will open it up for public comment.
Please step to the podium and raise your hand if you'd like to make public comment.
Beth Capel for Health Access. Since I trust I'm standing between you and lunch, a few brief comments. First, we appreciate the informal comment period. We recognize that with emergency regulations, that is not required. We do hope the full public comments will be posted because we find them helpful in understanding the development. With respect to consulting with the other agencies with respect to tangible net equity and reserves, we appreciate the office's caution in doing that, but we assure you that every one of these plans has ample tangible net equity, sometimes 2,000%, which seems of what they're required to have, which seems to us more than sufficient. And finally, we continue to regard these penalties as modest at best. And we won't stop saying that. Thank you.
Thank you. Looking virtually. Seeing no hands raised, back to the podium. Right, that concludes public comment on this item and I believe takes us to lunch. The time is 12:17. We will reconvene at 12:50. All right, we're just about ready to get going.
All right, well, welcome everybody. We'd like to reconvene the meeting. Could we have roll call, please?
Dr. Sandra Hernandez,
Here.
Secretary Kim Johnson, Richard Kronik, Ian Lewis,
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan,
Present.
Don Molds, sorry. Thank you. 5 in attendance.
Great. So let's move on to the spending target enforcement. I think I'm going to give this to you, Vishal and CJ, yeah?
Yep.
Or maybe CJ first and then Vishal, I don't know.
Yeah.
Some version of that. All right. Tag team.
Elaborate on this one.
Right.
Yeah. My name is CJ Howard. I'm the Assistant Deputy Director over the Healthcare Spending Targets Branch. We'll now return to what has been an ongoing discussion of spending target enforcement. And today we'll introduce the topic of spending target penalties or more specifically, financial penalties connected with failing to meet the spending target or exceeding the spending target.
Can we just acknowledge that Board Member Kronik just joined us, so he's also with us. Thank you. Go ahead, CJ.
All right, next slide. So prior to getting into the substance of financial penalties, we want to circle back on a topic that was raised at last month's board meeting. The question raised related to the goal or goals of performance improvement plans and whether their purpose is to facilitate entities into coming into compliance with future targets or to look backwards to account for prior excess spending or spending above the target that may have led to the implementation of a performance improvement plan. To answer this, we look to applicable statute. First, we have an excerpt related to the legislative intent and indicates enforcement should be progressive and that entities are to be assisted with coming into compliance with targets through technical assistance and performance improvement plans. We then have a second excerpt focused on performance improvement plans, indicating that performance improvement plans or PIPs are the strategies entities propose to implement to improve spending performance within a specific time period and to come into compliance with the spending target. So next slide. So OCA's analysis of this statute is that PIPs are forward-looking to accomplish the intent of assisting entities with coming into compliance with spending targets. PIPs provide the office and healthcare entities with an opportunity to learn about the causes for spending growth and which strategies, adjustments, and action steps lead to positive and sustainable change in the system and ultimately lowering costs for consumers. If the board wishes to account for inflated baseline costs resulting from exceeding the target, it could consider exploring adjustments to targets. And also through approving the scope and range of spending target penalties that account for each year of missing the target in conjunction with failure to implement a PIP. We'll begin to scratch the surface of this last point in today's discussion, and we'll continue these discussions in future meetings. So now getting on to the substance of today's item, we'll start as we typically do with a review of some pertinent statute. First, we have language about the board's role. The board approves the penalty scope, range, and justification factors, reviews and provides input on penalties, and the board can hold closed sessions when necessary to discuss confidential information. Next slide. Here we have excerpts from statute on the office's authority to assess penalties as part of progressive enforcement. I want to note that the statute says penalty amounts are initially commensurate with the failure to meet the targets and an escalating amounts for repeated or continuing failure to meet targets. Statute also mentions penalties for entities that are repeatedly non-compliant with performance improvement plans. Next slide. This section of statute discusses some limitations on penalties. The director may assess financial penalties when an entity is not compliant with a PIP and does not meet the target. Thus, if an entity is compliant with a PIP and does not meet the target, OCA would not assess financial penalties for failing to meet the target. There's also a list of factors OCA must consider when determining the penalty, including the nature, number, and gravity of offenses, and the fiscal condition and market impact of the entity. Next slide. So this is the last section on the statute. We have sections from statute that outline responsibilities for OCA to consult with other state agencies like the Department of Managed Healthcare, the Department of Healthcare Services, the Department of Insurance, and the Department of Insurance to discuss penalties for entities they also regulate. Next slide. We want to be clear here about the various instances where financial penalties may be assessed. So first, when an entity is not compliant with an approved performance improvement plan and does not meet the spending target. This instance is the focus of today's discussion. These other items and areas where penalties can be assessed will be discussed at future meetings. But just to make sure that they're put out there. Second, after the implementation of one or more PIPs, if the entity is repeatedly non-compliant with their PIP, the director may assess escalating penalties that exceed the commensurate penalties. And third, when an entity, when any of the following violations occur, like repeatedly neglecting to file or implement a PIP. We would refer to these, I think, in prior meetings as the H1 penalties. And again, these will be reserved for another discussion topic. So for today's focus, we can go to the next slide. Financial penalties. So today's focus is financial penalties for failing to meet the spending target, which can be assessed when an entity is not compliant with an approved PIP and does not meet the spending target. Penalties cannot be assessed when an entity is compliant with an approved PIP but does not meet the spending target. Under these circumstances, penalties can be assessed if an entity repeatedly fails to implement a PIP, and a PIP can be modified until the spending target is met. So we know that OCA is likely to encounter many different scenarios in terms of how enforcement can play out when determining how, encounter many different scenarios when determining how enforcement can proceed for entities based on several factors. For today's discussion, we will focus on following this example scenario. The scenario, again, is just one example to ground our analysis and discussion for today. In the scenario that we're going to discuss, an entity exceeds their applicable target. They have proceeded to implement their PIP for 2 years. After 2 years, OCA determines that the entity failed to comply with their approved PIP. OCA also determines that the entity failed to come into compliance with their applicable target, and OCA then determines that an entity will proceed to a financial penalty. On the next slide, we will put this scenario into a timeline to further illustrate the broader enforcement context that would have preceded getting to this stage at which the office is considering a financial penalty for exceeding the spending target.
Yep, I'm getting there. Sorry. CJ, that's a hypothetical, not an actual proposed timeline, right?
Correct.
Yeah, I just wanted to make sure I understood.
It's just for the purposes of this discussion, we wanted to ground it.
That's what I thought. I just wanted
there are
to make.
many combinations and permutations of how this could play out.
Yeah.
We're just saying for today's, to try to isolate as many what if scenarios, we're saying, let's talk about this one and then we can extrapolate broader rules. So put this into context. Let's just assume, for sake of today's discussion, that the entity exceeds the 2027 spending target, for which the data is submitted in September of 2028. In late 2028 or early 29, OCA sends a letter notifying the entity that they've exceeded the target, and the entity has 45 days to respond. The entity provides additional information, and OCA confirms that the entity, in fact, did exceed the target. The additional information didn't change that assessment. OCA would then provide the entity with TA. OCA then assesses the entity and other entities' performance relative to the target in that year. And OCA determined that the entity must file a PIP. OCA approves the PIP for, let's just, for sake of argument, 2029 and 2030. OCA then determines that the entity was not compliant with the PIP and they did not come into compliance with their spending target in 29 and 30. And then OCA is now at the stage where they're assessing a financial penalty. And so the question today is, how would we quantify or establish that penalty?
So Jay, can I ask just one question about the timing? So the PIPs are for calendar years? No, are they necessarily?
In this instance, I think we're thinking of them as performance years. I think there's still,
and so just on this graphic, late 28 or early 29, OCA sends a letter. By the time we got to a PIP, it would presumably be into 29. And so the PIP, the first PIP could cover 29, even though it might be starting in May or April, or the PIP might be approved in May or April, but would be covering the full year.
It could. Okay, so next slide. So considerations as we're thinking about spending target penalty structure. The penalty needs to provide an incentive to implement a PIP so that entities come into compliance with the target, and likewise also provide an incentive to come into compliance with the spending target. Statute indicates that the penalty should be initially commensurate with an entity's failure to meet its applicable target. Statute directs and enables OCA to consider a number of penalty adjustment factors to determine the final assessed penalty amount, including but not limited to the nature and gravity of the offense and the entity's fiscal condition and market impact. Entities would have multiple years in this scenario and opportunities to come into compliance with applicable targets through implementation of PIPs before the penalties are assessed. So with that context, OCA is making an initial recommendation. So OCA recommends a penalty structure that is initially commensurate with the entity's failure to meet the spending target with adjustments. So we're going to talk first about initially commensurate, and then the next slide we'll talk about these potential adjustments. So in step one, OCA would first calculate penalties that are initially commensurate with the degree to which an entity exceeded the spending target. Initially commensurate is the difference between an entity's actual spending growth and what the growth would have been had the entity met the target. If we applied this to a sample of the 2023 spending growth data, initially commensurate penalties, and I want to remind everyone these are prior to application of penalty adjustment factors, and obviously we're using years before a target was in place. So again, hypothetically, on the lower end of smaller entities that might have missed the target by smaller amounts, we're looking around 4 million, and on the upper end, these would be larger entities that may have had larger amounts of spending. It would be closer to $350 million could have been the initially commensurate calculation. Next slide. So next, OCA would adjust the initially commensurate penalty for a variety of factors, including but not limited to the nature, number, gravity of offenses, the fiscal condition of the healthcare entity, including the revenues, reserves, profits, and assets of the entity, as well as any affiliates, subsidiaries, or other entities that control, govern, or are financially responsible for the entity or are subject to the control, governance, or financial control of the entity. Sorry for the long-winded nature of that one. Direct from statute, the market impact of the entity, and then also input from other California state agencies, penalty justification factors that would be approved by the board. We think that many of the penalty justification factors could mirror the enforcement considerations that we've discussed in prior meetings that could explain a portion of the entity's excess spending growth. We think that these could be factored in when determining the financial penalty amounts. So these could include investments in primary care, changes in state and federal law, or others as determined by the board. And then escalating amounts for repeated or continuing failure to meet the targets. The final result could be an increased or decreased assessed penalty compared with the initially commensurate amount. Just a couple things before turning it over to the board for discussion. I just want to share some alternative penalty structures or options that we explored. So one is a penalty multiplier. So we explored applying a predetermined multiplier to entities' initially commensurate penalty. Multipliers could be tied to factors such as the number of years the entity exceeded the target. This predetermined approach, we think, conflicts with statutorily required adjustments and considerations. We also explored a market share paradigm or structure or approach that calculates an entity's penalty by first calculating the total statewide excess spending growth or total statewide spending above the target, and then assigning a portion of that statewide excess spending growth to each entity that exceeded the target based on the degree to which the entity exceeded the target and the entity's statewide market share. While this approach considers an entity's impact on the market and contribution to growth in excess of the target, penalties would not always correlate with an entity's spending or spending growth. I'm going to take the liberty of taking one slide out of order. So if we can go to the future discussion items. So before getting to the board's discussion, I presume this presentation raises several questions, some of which we are aware of and plan to address it at future meetings. Today, we only looked at one scenario and select elements of financial penalties for failing to comply with the spending target. The office will return to the board with the following. What should the penalties be under H1? So those are I mentioned those at the top. These are such as repeatedly neglecting to file a performance improvement plan with the office. What other penalty adjustment factors should be considered and approved by the board as penalty justification factors, though we certainly welcome input on these today through the board's discussion. And then what years should penalties be assessed after an entity fails to comply with a performance improvement plan and misses the spending target? All right, so we can go back now. So, yep, now we're looking for discussion from the board. I'll remind everyone that the green arrow indicates that this is a discussion item that will eventually lead to board action or vote. In this case, to approve the penalty scope, range, and justification factors. We're looking for any initial feedback on the office's proposed penalty structure.
Dr. Pam.
Actually, this is a question about how we get here. So in terms of the performance improvement plan, as you clearly outlined, they both need to exceed the target and not meet the PIP. And I know there was a little discussion about, you sort of threw out 2 years. It's not a formal proposal, just an example, et cetera. Are we thinking about how we structure this? How we structure PIPs? I mean, I realize that, the entity itself is going to play a role, but so for example, when we say a PIP, should there be required, there's actually stages in the PIP where it's commensurate. So in other words, we don't have to wait for 1 year, 2 years, 3 years, 4 years before we can say, like, they're like, in other words, a PIP would say, in year 1, you will do this, or you will say that you will do this in year 2. And therefore, the not meeting the PIP does not have to wait till we get to the end of the PIP, but there's actually benchmarks along the way that if they haven't hit that benchmark, technically they're not meeting the PIP, right? So that we're not sitting there, and some things may take some while. So some of those may be process benchmarks. So I realize that we're talking at the end of the penalty, but in the process of getting there, and when this, OCA can take action, are we thinking about how we're structuring the PIP in ways that allow us to not wait till the PIP is concluded to be able to say that if they're not hitting the benchmark, then they're not meeting the PIP?
Yeah, I think that could happen on a case-by-case basis with the entity and on a PIP-by-PIP basis. Some entities may actually assert that they would prefer to have a 1-year PIP, that they're going to do certain activities that are going to get them to be compliant. Others, we can approve initial PIPs for up to 3 years, I believe is the statute. Oh. So that's what we chose to, because it was in the middle, sort of. And yes, I think that there's a world in which we could determine early or see that that they're not compliant with the PIP if the PIP had milestones built into it that within X months specified activities were to occur, and that those are, we clearly see no evidence of that.
Well, I would suggest that we think about how we want PIPs to be structured ahead of time, right? The exact details of each PIP is going to depend on the entity, but from, I guess, an enforcement perspective, we may want to think about the structure. Yes, the actual details will be dependent on the entity, but from an enforcement standpoint, we may want to say, yes, you need to determine our, benchmarks along the way, so that basically we don't end up with a PIP where nothing happens for 3 years and they're clearly not making progress, but the PIP isn't over, so they haven't violated the PIP, right? So that before, so that, and also in terms of our guidance to the entities when if they are required to do a PIP, so that we can act in a more timely manner. Some of this should also be tied to when we get data or how frequently we get data as well. But anyway, just want to throw that out there. I realize it's another layer on top of like what the penalty is going to be, but basically what will end up triggering action.
Don, did you want to get in?
I was just going to sort of say amen to all of that. I think one of the major concerns that you've heard from the board has been the fear that the PIP is used to restart a clock in perpetuity, and that makes folks anxious. We have this build-up period before we start collecting data. I mean, it's been a while now, and the fear is that the PIP process could extend it. I think it would be an important safeguard against that possibility. So I would also encourage that we actually, rather than just kind of, doing it on a case-by-case basis, that we really lean into the milestones.
Yeah, I mean, I think what part of this highlights is that it'll be important in terms of making sure that the office is approving aggressive PIPs, if you will.
Elizabeth?
And I do really appreciate the point about the milestones. And we do have as part of the PIP process reporting requirements, right? So there's milestone X, you got to report on it at 3 months or 6 months. And then, so what you're suggesting is that if there's a PIP milestone that isn't met in 6 months, for example, that penalties could accrue at that point rather than waiting till the end of the 2 years, for example.
Elizabeth?
I strongly support that and would want some sort of measurable improvement within 6 months, even if it's not the whole thing, so that it is clear if and when a penalty would be assessed. But I also had a question are these penalties additional to the penalties that they would have gotten just for missing the target, or this is just these are
the penalties for missing the target, because we don't ever get to assessing penalties unless and until someone's exceeded the target and has violated the PIP or not complied with the PIP.
So then there's like no reason not to go for a PIP and just extend it, right? There's no financial incentive to try to get it right the first time when you can just extend it.
Well, the statute envisions and requires this progressive enforcement approach. So we do have to do the PIP process before. That is a step.
Right. I was just wondering if there would be compounding penalties. So you didn't make, let's say you didn't make it in 2027.
Yes.
Does it?
Yeah,
there's some way to structure it.
I think that's also what we're planning to come back
to talk about that as
So there is a portion of the statute that does talk about, adjusting the PIP for repeated violations. So CJ went over that statute and we'll come back to the board with further discussion about that.
Sure.
Could we go back to slide 83, please? Because I'm still not kind of following this
80.
Argument that if a covered entity exceeds the target, that there's no way to get that money back. I mean, is 83? 83 on my, maybe I've got a different numbering system.
Yeah, I have that.
Yeah, it's the one that says statute on the top.
Authority to assess penalties. Authorities to assess penalties.
Yeah. Yeah. So as I read A4, that commensurate with the healthcare entity's offensive or violation, the director may take the following progressive enforcement actions: assess administrative penalties and amounts initially commensurate with the failure to meet its targets. So why doesn't that mean that if an entity failed to meet its target, that the director could assess penalties for that?
I think it's taking that out of context.
This is the portion of the statute, the 3 dots, that you do have to go through the steps.
Okay.
The broader context where an entity's penalties may be assessed when an entity also is not compliant with the PIP and is still not compliant with the target.
Right. But is it clear from that if it's not compliant with the PIP and not compliant with the target, that the penalty can't apply to the year before the PIP.
And that's what we're going to return to on a separate discussion at a future board meeting.
So we're leaving open.
We're trying to,
possibility
we're going to
that
hold.
That is that might be possible.
Potentially
To Elizabeth's question.
possible. Ian, did you want to get it?
Yeah, I mean, I think the penalties, the penalty structure is beginning to make sense to me, the way you've spelled it out. Although the scenario really draws out the heartburn in me, right? Like I'm looking out into years 2030 and beyond, and I really don't know if many people in the service industries, especially in this state, will have access to affordable care at that point. But that aside, just going back to the PIP and what the target of the PIP is. I hear you saying the PIP is forward-looking, and so the goal is to bring it into line with future targets. So that allows, in the scenario, you could have an entity which exceeds, let's say, double the target, gradually ratchets down its spending over 2 years of a PIP, complies with its PIP, and it's at a higher baseline now than its competing entities, and then it's motivated to do the same thing all over again. So we could, if I understand this rightly, the board could set an entity-specific target that, if it wanted to, bring it back into line with where it should have been. I guess I want to understand, one, can we actually set an entity?
You're sort of saying, is the target able to be moved?
Yeah, can they move the goalpost?
Yeah.
Thank you. Much more
I just want to
eloquent.
make sure I understand.
Appreciate that. I want to make sure, yes, we can set an individual entity target without, I mean, maybe we need to set a sector first, you'll tell me. But then process-wise, I mean, how do we approve a PIP if we haven't already made that decision? Would we have to make that decision in the same meeting in the same discussion as we're considering the PIP?
I would probably separate those two items. So one is kind of their compliance with the PIP. And if you're I guess, just to make sure I'm restating what you said. So you're saying that if they successfully complied and then they're at a higher baseline because of their past performance, and then you're concerned that they're going to do it again.
Well, let's say that, so the target's 3.5% this year. They exceed by 7%, double that. By the time they're done with their PIP, they're, several percentage points ahead of where they would have been had they complied with the target from the get-go. I'm uncomfortable with that. I would like to argue that we, in following your recommendation, then have an individual target that brings them back into line with where they should have been. But it's not clear to me how we do that if we're approving the PIP and then moving on to discussing an individual target, or do we discuss the individual target and then approve a PIP, or both at the same time?
Or as part of the PIP, what the target should be for that entity. I mean, that'd be another.
Yeah, the PIP wouldn't be the vehicle for adjusting targets. That would be kind of the target setting process that the board has. So you could, certainly for input on kind of which healthcare entities to adjust targets for, you could look at their historical spending growth and levels of spending as well. And that could be an input in your your deliberation on which entities to set a lower target on. So I would see those as kind of separate activities. But they would, they would need to finish their PIP. In this scenario, you're describing that they completed it. But then you're concerned about future behavior.
Well, another way to think about that is, could the PIP actually set a target in it as one of the milestones that they either hit or they don't? That would be another way to address this issue, I think.
Or even if it can't, could sorry, in Ian's example, if the target is 3.5% and an entity comes in at 7%, can the PIP be designed so that the subsequent year is 0? Without necessarily setting a separate target, but just saying, you know, this PIP is supposed to get to 0, and that would kind of make up for that first, 3.5% overage.
Yeah, we'll have to take that back. It's kind of combining a target setting with performance improvement plan. So we'll want to make sure that we take a closer look before we respond to you.
I think the point here is that I'm just going back to this notion of having milestones that are actually measurable in real time. Number one, it would suggest that those PIPs should be shorter if we actually are going to want people to get into compliance sooner. And if we're talking about milestones within a PIP, I don't understand why we couldn't name an expectation about spend as part of the milestones.
Yeah, we'll absolutely take it back. And so this is a very helpful discussion.
I mean, the only other question I had is, could you imagine a scenario where somebody, an entity exceeded the spending, went on a PIP, complied with the PIP, but didn't hit the spending target? And then not be subject to any penalty at all? Like how could that happen? And wonder what circumstances might that happen based on what you said?
Well, I think we need to have meaningful PIPs. So if there were a PIP that were yes, that could happen. So it really is incumbent on us to have PIPs that are really geared toward addressing the spending growth.
Yeah, the notion of having a PIP that an entity complies with and they're still not meeting the spending requirement seems to me to completely undermine the whole purpose of having a PIP. Am I missing something? No.
Wouldn't everybody get a PIP in that case? I mean, if it's a pass from meeting the target? Or wouldn't they seek it? I just think the PIP should include the target.
What'd you say, Elizabeth?
The PIP should include hitting the target, to your point.
I think you make a very good point, and I wholeheartedly agree. The one PIP that I'm aware of is the MGH Brigham PIP, and I haven't gone back and looked at it carefully, but my memory of it is that MGH Brigham could easily have satisfied the conditions of that PIP and still not have met the spending target. That doesn't mean that our PIPs need to look like that, but that, something to be careful about.
Yeah, I would say that the PIPs are about coming into compliance with the target, so that is clear. It's just, I think the board is posing a new question, whether you could have a lower target in the PIP. So that's something we'll have to come back to.
Other questions or comments on the board? Richard?
Yeah, I mean, I think this speaks to exactly, how the PIP is structured. And so, for example, there is an issue of, can we simply say in the PIP that you have to hit a certain cost spending amount, right? Without detailing what they have to do, right? Or having them suggest what they have to do, because there's many things that influence the market, right? So supposedly there's an inflation spike. Maybe the president just declares a war that causes prices to go up or increases tariffs unilaterally. And then they miss the target, even though they did everything we asked them to. So, I think that, I think the question is exactly how we structure, and that's why, how we structure those PIPs, right? And exactly what are the benchmarks, right? Is a benchmark, are we going to simply say we want a certain outcome and we don't specify, and don't forget some of the ways, there could be dysfunctional ways people could quickly, just like, it's like dieting, right? I can certainly, take diuretics and suddenly drop my weight, but that's not a long-term solution, nor is it particularly healthy, right? We can have a hospital basically say, fine, we'll close a bunch of units and we will get our spending down, but that is not necessarily a good thing for the community, right? Or laying off a bunch of people. So we have to think about what exactly is our PIP. Obviously, we want people to do things in a functional way, but may not always result in, hopefully it does result in, that's the intention, but so I'm just trying to clarify exactly how that how this PIP is going to be structured and what are the expectations in the PIP. Are we, there may be several process things we would propose, but do we just simply say, you have to hit this target or else, and then you're in violation, and we leave them free to do whatever they feel they need to do to hit that target, which may not necessarily have results that either we nor the people in the community are happy with. So I think there is some discussion about, we're talking about penalties, but ultimately, to me, one part of it is exactly what's in the PIP and what's the expectations for the PIP. So hospital or whatever, I mean, I can pick hospitals because many entities we do proposes something, and then we say not good enough, and then they're going to say, okay, so what do you want? And then we've got to decide what we're going to tell them. Well, then if it's not good enough, what do we want to tell them that they have to do that they may not have proposed in the first place? So I think this is an important discussion to have exactly what's our expectations of the PIP, and what are we going to how are we going to structure that in a way that will make it effective, but also not result in basically, I would call it dysfunctional behavior or actions that basically are not beneficial.
So I think this has all been, helpful and given us a lot to think about. We do want to, I think, return to the question. So I think you're asking really important questions about because we only get to the question of penalties if someone has not complied with the PIP, we kind of jump back into what might that look like, and that's really important. And also, we would still seek the board's feedback, if any, about the penalty structure that CJ presented. I don't know if there's more framing you want to give.
Some of the other things, and I realize we're only doing certain pieces today because some of those, I guess, some of those adjustment factors, right? So, for example, fiscal condition, right? If an entity is in poor fiscal condition, does that mean fewer penalties, or they can't afford it, or whatever? So I'm also interested in how those interact, right? Market share, of course, will have a bigger impact on the community, depending on, they have a very large market share. So how that interfaces with how we decide how much the penalty is. So we have a struggling rural hospital whose financials don't look so good, but they keep exceeding the cost target. Do we say we're okay with that? Or do we adjust the amount of penalty? And then some other hospital says, well, wait a minute, how come that hospital, and even though we're less in excess of the target, but this hospital is way in excess of the target, it has a small penalty, and then we got a bigger one, right? So we're going to have to deal with that too, and exactly how these adjusters work. So, I mean, how much is a case by case versus guidelines, right?
Guidance on.
Yeah. Unfortunately, I don't have an immediate answer to that right now.
Okay. Other thoughts about this piece and these potential areas for adjustment?
A process question. It's a green arrow. Eventually, we're going to vote on a penalty structure. Once we have voted on the penalty structure, if an entity enters into a PIP and doesn't fulfill its PIP and doesn't meet its spending target, what is the process for then assessing a penalty? Is that done by the office, or does that come back to the board?
By the office. The board could provide input on individual entities.
I'm glad to hear.
It's like they can on PIPs as well.
Glad to hear both of those answers. And I guess, to the question, which now has gone away again, I mean, yeah, the answer is, for me at least, is yes, that makes sense. But then as Richard, as Dr. Pan suggested, the question of, how those adjustment factors would be applied or figured out is the tough one, and you're looking for advice. And I don't know that I have much kind of generalized advice. I mean, that's kind of the problem, right? That it's going to I mean, I guess one somewhat general piece of advice is to try to the extent possible, not to make adjustments, because that way lies madness. On the other hand, there will be situations where it certainly makes sense to apply adjustments. So that's kind of not very helpful.
When you listed under penalty structure, step 2, the market impact of the entity, what are you thinking about there?
Yeah, we're welcome to input on this as well, but we're thinking about it kind of it could be interpreted in a few different ways. One could be size in terms of market share.
And how would that influence the penalty in your mind?
It's essentially kind of, for larger larger entities that have kind of more of an impact on the market. This would be like if we wanted to have different penalties for different types of entities.
So we have a lot of consolidation in the market today. So market impact, are you talking about market share? Or are you talking about the consolidation in a market? I say you, I realize that's in statute, but I think we should be clear about how we're thinking about that element. Or try to get clear.
Yeah, it could, we're certainly open to feedback on kind of how to operationalize market impact.
I mean, I would read market impact in they're exceeding the cost, the expenditure rates, the targets in a market that is having influence on that market. That would be how I would interpret this. But bless you. But I don't know if that's what the legislation was meant to get at. Elizabeth?
You could, an alternative reading would be, what if it was the only provider in a rural area and the penalty would put it out of business?
Yeah, I think Richard meant.
So I do think that needs clearer definition. I would think it would be impact on affordability at the market broadly.
Yeah, I mean, I do think that it's interesting, probably both ideas at the same time, which interesting are contradictory. One is that obviously a entity with a larger market impact, when we call it market share or something, if they exceed the target, of course, will then drive the overall spending in at least that market area. And by the way, this, we have a statewide target, and then we got to think about California being a very big state, especially in comparison to any other state, including the ones that already have these entities, that you have an entity that has a large market share. Therefore, the more they're over the target, the more they basically drive the entire market over the target, right? In terms of hitting our target spend, that one could argue that, well, maybe there should be more consequences because basically our overall goal is to try to, reduce overall spend, right? We're not trying to nitpick particular entities, but how they contribute to the overall. And someone could argue that a smaller entity, well, because they're not contributing as much to the growth is maybe, and again, whether it's absolute or relative penalty relative to their size, that's an whole other thing. But then there is the issue about also because of their market share, whether the penalty would lead to a problem in access, right? Because this is, again, if you're a large portion of the market for that area and the penalty is such that it might compromise, like I said, we could say a struggling rural hospital, then it would have an outsized negative impact on access as well. So I think both of those may come into play. I know someone mentioned legislative intent. I guess I technically was part of the group that helped write this. I will probably argue both of them are probably in mind different people at different places. So, but I do think that part of it is we're trying to figure out not just for each individual entity, but collectively, right? That's why we have a statewide target, is to try to slow down the overall spend, I guess, across the state, including in each of the individual markets.
Yeah.
So I think about the plain reading of what's on the board right now. If in the case of a monopolistic rural situation, presumably that, risk of putting a business under would emerge as the office looks under B at the fiscal condition. My reading of the market impact, I think, would be, if you're driving, your overages are driving the cost of care in the entire market, that's reason to drive up the penalties from the initial.
Also, we should remind ourselves that part of the challenge in California is these not particularly high functioning markets in the first instance. And unless we are approaching this as a partial solution to that, we're not going to solve the problem we're trying to solve here.
I just a question on, not sure we're being helpful here, but under adjustment factors that might be taken into account, one of the things that's listed here is changes to state and federal law. Changes to state or federal law would apply to all entities.
Probably not to all entities equally. We probably also know that there will be some entities that miss the target and can explain some portion of it based off of a particular change to state and federal law. Would it make sense that we've still determined that you've grossly exceeded the target, you've not implemented your PIP? Should we, as we're thinking about that difference between what spending under the target would have been and what their actual growth was, there may be portions of that that are explainable to some of these. Should that be factored out from the initially commensurate delta? I think that's our question to you all.
I would probably say that was probably the intent, right? That if there are changes to state and federal law that drove some, a increase in spend, that we probably shouldn't be penalizing entities because those are factors, out of their control, barring whatever government relations department they have. But yes, that those are factors essentially more out of their control. It doesn't mean you write off the entire thing, but if there's a way to assess the impact of that, right, that probably should not be penalized if we put in some certain mandates or so forth that then resulted in greater spend. I think perhaps people are thinking about coverage mandates for certain health plans, right, and so forth might cause a certain increase, right, and that we put that in statute, or the federal government doing something that has an impact as well, that the entity shouldn't be penalized. Obviously, there's a question of how you measure it and determine that amount, but at least for at least reasonable attempt to assess the impact of that should not result the penalty for the entity.
But to Sandra's point, that makes sense if this change is affecting one entity quite differently than other entities. If it's a change that's affecting all entities more or less the same, that should be taken into account as we're doing the target setting exercise, and wouldn't be a justification for an adjustment for any individual entity, unless, to CJ's point, it was affecting that entity much differently than others.
Anything else on this? Secretary, I'll give you back the chair and feel free to take the floor.
Thank you for covering. Appreciate that discussion, and we will open it up for public comment.
Please step to the podium or raise your hand for public comment on this agenda item. On any other items, please save it for the general public comment at the end of the meeting. I noticed a number of hands raised, so I am going to start with our virtual attendees. Jane Thomason, I see your hand raised. You should be unmuted on our end. Please go ahead. Jane, you might need to unmute on your end. The button is usually in the top right-hand corner. But you're unmuted on this end. We'll give it a moment. All right, I'm going to move, Jane, we'll come back to you. I'll move to Katie Bassler, also a virtual attendee. Katie, let's see if we can hear you. It'll take just a moment. All right, Katie, let's try. Yeah, we got you.
Wow, this is amazing. Good afternoon, board and staff. I'll begin to say that I'm finally excited that I finally figured out Teams. Katie Bassler from Salinas, Salinas Valley Federation of Teachers. I speak on behalf of so many workers who continue to struggle in Monterey County. We are in strong favor of the board's proposed penalty structure on entities that do not meet the established PIPs and spending targets. Access to affordable health care is a top concern of educators and other workers in Monterey County whose salaries have continued to be stagnant for the past few years and are looking so for 26-27. Specifically with our group in Salinas, our healthcare, unfortunately, our plan right now has initial rates increasing 9% for 2027, and that's on top of the 15% that we're experiencing currently. Educators in Salinas have experienced a reduction in take-home pay this year due to the increased healthcare costs, and we see absolutely no end in sight. With two of the 7 highest cost hospitals in our county, we continue to have serious concerns about the ability to access affordable health care. The comments from the community forum that the board facilitated mirror the environment for our educators. We are foregoing health care due to the economic impact on home budgets. The hospital systems need to recognize that they are continuing to hurt the community that they are charged to serve. The pattern of any cost of living increase being eaten up by the cost of healthcare is unsustainable for Monterey County workers. So again, in closing, the educators of Monterey County and the workers support the board's proposed penalty structure and provide us at least some hope that these hospitals will be held accountable if they don't meet the targets. Thank you so much for all of the work that all of you do.
Thank you. Back to the podium. Go ahead.
Beth Capel for Health Access California, and very pleased to go after our colleagues in Monterey County who've done so much to illuminate the impacts of high healthcare costs. I don't know if we would be where we are today without all their work, so our thanks to them. Health Access supports the staff recommendations that the penalties should be initially commensurate with an entity's failure to meet the target. That is consistent with the letter and the spirit of the law. The board has had an important discussion today about how to rebase so we get back to where they should have been. Let me say it that way. And we will take that back and think about it in the context of the law, because that's, I think, should be the goal of trying to get the entity to where it should have been if it had complied with the target. The point of the law saying that the penalty should be initially commensurate is to say that we as California are serious about changing the course in terms of affordability, and the board discussion affirms that today. And we appreciate the discussion the board has had. A few other points. You've had some of the discussion that we had during the 5 or 6 years of developing the legislation about the differences between types of entities, the distinction between the haves and the have-nots. You know, there's a difference between a small rural hospital that's distressed, that has 2 weeks of cash on hand and no money in the bank, and a hospital with $1 billion endowment, like one of those in Monterey, or between a managed care plan that's barely meeting financial solvency requirements and one that has such ample financial solvency, they're 2,000% of the required tangible net equity, or an entity like United, which controls Optum and PBMs and more.
2
And
minutes.
so the law gives the director the authority to look not just at the larger system, but also at controlled entities, so that you could, I say, look up, look down, when you look at the organization chart. So that is very powerful language on the fiscal condition of the entity, and it's designed to assure that you don't bankrupt a rural hospital that's a key provider, but on the other hand, the penalty is appropriate for a large entity that's well able to meet it and has the capacity, the administrative and organizational capacity to come into line with the target if they chose to do so. We appreciate the board's discussion about things like market impact. Again, we were thinking about the whole range of situations that the board has discussed, whether it could be actually a relatively small provider group, but that is a monopolistic player in a key market like Reading and Red Bluff, or it could be a very large player that moves an entire market, or moves. There's a reason healthcare costs in Northern California are higher than those in Southern California. It's usually summarized with one word. So, thank you.
Thank you. Looking back virtually, let's try it again. Jane, you should be unmuted on our end. Please go ahead.
Oh, great. It's working on my phone, but not my computer. Can you hear me?
Yes, we can. Great.
Awesome. Jane Thomason with the California Nurses Association. As registered nurses, CNA's members see how increased healthcare costs harm patients. When patients delay care because costs are too high, they come in sicker and needing higher levels of care. So as the board develops the penalty structure for spending targets enforcement, it is important to ensure that there are clear consequences for non-compliant entities. CNA has a lot of experience with different agencies in California and their varied enforcement processes. And in our experience, the most effective processes are the ones with the clearest, most impactful consequences for regulated entities if they fail to comply. Any measures that relax or weaken consequences for non-compliant entities, especially after they've been through a potential multi-year PIP, should be avoided. It's also really important to ensure that any financial penalties are not used to justify workforce-related cuts. That should not be the impact of this process. One more aspect here to highlight that is part of effective enforcement processes is engagement with workers and others who hold really vital insights about the regulated entity's day-to-day activities. It's important that OCA engage feedback from worker and community hearings early in the PIP process and during this enforcement process to make sure that all relevant information is gathered as you're thinking about compliance. Thank you.
Thank you. Back to the podium.
All right. Ben Johnson with the California Hospital Association, and appreciate the opportunity to comment on this important issue. First, we agree with the office that PIPs are forward-looking and a mechanism within the enforcement process to assist entities in meeting the spending targets as promulgated by the board according to that process. And further, they may not be imposed and implemented in ways that undermine access and quality and must be designed accordingly, as the discussion touched on. We would ask for clarity regarding the timelines for imposing a PIP on hospitals given reporting schedules and what slide 89 implies regarding potential retroactivity. For example, if a PIP is established in December 2029, surely it couldn't apply to the preceding 11 months to require actions back in time. So we would like to see clarity on how OCA will ensure that those are forward-looking opportunities to reduce spending. Second, It is critical that the penalties be reasonable and appropriately account for an entity's individual circumstances, their good faith efforts to reduce their spending growth. And OCA can look to its approach on penalties for the non-submission of data for inspiration, where initial penalties scale gradually and progressively to encourage compliance rather than merely being punitive. The penalty adjustment factors laid out by OCA are essential components for determining an individual entity's penalties, and most critically, the penalties cannot be set at levels that would ultimately threaten access to care and sustainability of healthcare providers. For example, our data team looked at what penalties would have been in 22-23 if set at levels equivalent to the target. The result is that penalties would exceed operating earnings for 2/3 of the hospitals throughout the state, and penalties at these levels would clearly endanger access to care. Add that, well, as we'll get into in a minute on the next item, this is in large part driven by the enormous volatility in OCA's measurements of hospital spending, and shows that OCA will ultimately need to assess compliance with targets and with PIPs on a multi-year basis. Finally, we agree that penalty justification factors should include consideration of unavoidable or desirable spending growth, such as factors like economic trends, new state mandates, and investments in patient-centered care. We look forward to engaging on these matters in the coming months. Thank you.
Thank you. Looking back virtually, Caesar?
Good afternoon, everybody. Cesar Lara with the California Federation of Labor Unions and the Monterey Bay Central Labor Council, and a resident of Monterey County, and really want to thank the staff for moving forward with these recommendations and understanding what is the purpose. The purpose is to change behaviors and ensure that healthcare is affordable and accessible to all residents in a given market area. And we need to take into consideration that this should not be a cost of doing business for hospital systems. When we have a spending target and it's not met, we should, if it's after 36 months, after 11 months, after 10 months, be back on track with the spending targets going forward, and not walk away with an entity having, after 3 years, having a spending target that is higher than what was projected. And take, for example, Monterey County in the investigative study. If you convert that into a PIT, you could take into consideration multiple factors on why an entity is at its cost and why it's not meeting its targets. If it's simply like the investigative study shows that it's a lack of market stress, which means that they are allowed to gouge, because that's what the investigative study ended up at. We should take that into consideration when we look at a PIT, and make sure that, as a community, we have accessible and affordable healthcare for the residents, and make sure that, we are not leading anybody else. And if you take, for example, the Monterey County study, which looked at the cost of the staff and the nurses, that was taken into consideration, and it was shown as a non-factor. So as other entities go into a PIT, we should make sure that we really look and compare apples to apples, and understanding that global conditions could change things at the federal level or at the state level. It will be affecting all hospitals or group of hospitals. That should be taken into consideration into a PIT, and I think that that is logical. But at the end, we need to make sure that we stay to our mission to make sure that healthcare is affordable and accessible for all. Thank you.
Thank you. Looking back in the room to the podium, seeing no one at the podium. Back virtually, Frankie, I see your hand raised. Go ahead.
Hi, can folks hear me?
Yes, we can. Thank you.
Oh, thank you. So my name's Frankie Darling Palacios. I'm just a patient advocate here in LA County, and I'm also a parent. We just got off of a stressful month here in LA County, where the second largest schools district was set to go on a pending strike because one of the asks from the unions was access to healthcare. And some of the pushback from leadership was covering more people would be too expensive because of things like hospital-related care that comes with healthcare coverage. Our county is very expensive. We have hospitals that can spend hundreds and thousands of dollars on giant billboards around Kia Forum, SoFi, BMO, but still we face, thousands of dollars of care and face months-long wait lists for specialty care. And we don't have a way to check on how much it costs before we go in. So I know we are in a really unique place in this part of LA County than, rural hospitals, but we are also at a very similar expense of these hospital systems. We hope that we can get real change in the form of affordable healthcare aimed at primary care and preventative services, which improve outcomes and equity. We need care that we can afford when we need it and not huge deductibles and premiums driven up by like huge healthcare costs. Thank you.
Thank you. Looking in the room, no one at the podium. Celine, we see your hand raised. Go ahead.
Hi, thank you. Celine Betancourt with the California Pan-Ethnic Health Network. Just want to comment that we are in support of the proposal for the commensurate penalties that are dollar for dollar the amount over the target. As CPAN has been hearing from our partners all over the ground, folks are really need affordable change now. We can't wait, especially with all the changes happening to our healthcare system. Consumers are really struggling right now, and we need to be able to actually enforce the targets that the state is setting to ensure that we have affordable healthcare for Californians. I appreciate the work. Thank you.
Thank you. Looking to the room, no one at the podium, no hands raised. That concludes public comment on this item.
Thank you very much. Appreciate that discussion and the public comment received. We are going to turn to our last informational item on the agenda today. That's item 4E, the hospital measurement update for fiscal years 22 and 23 inpatient and outpatient hospital spending trends. And in addition to Deputy Director Pagani, we welcome Andrew Fair, the Research and Analysis Group Manager.
Thank you, Secretary. I'll start with some background information. From July through December of 2025, OCA convened a hospital work group soliciting input from key stakeholders on its approach for hospital measurement. At the December 2025 board meeting, we described how OCA will measure inpatient and outpatient spending using a combination of the hospital financial reports, another data set referred to as the patient discharge data set, and the HPD, or healthcare payments data base. In January, we posted what we're calling a OCA hospital facility to National Provider Identifier, or NPI, crosswalk on our website. We included a request to hospitals to confirm the NPIs that map to their California license number. We incorporated hospital feedback on the crosswalk, and we posted a revised crosswalk. And then with this month's board meeting materials, we also posted a facility level data set that uses payer-specific case mix index and average visit intensity to derive measures for inpatient and outpatient spending measures across commercial, Medicare, and Medi-Cal markets for fiscal year 2022 and 2023. So today we're pleased to share the results of our analysis. But before I get to that, I just wanted to provide a brief overview of some of the differences between OCA's measurement methodology and other approaches that you all may be familiar with. So I'll cover some of the differences in approaches between OCA's approach and the Federal Hospital Price Transparency data, and then the RAND Price Transparency Initiative. For data sources, RAND uses claims data. The Federal Hospital Price Transparency Initiative uses hospital disclosed contract negotiated rates for select procedures. For OCA's approach, we're using a combination of financial data reported to the department, patient discharge data, as I mentioned, and healthcare payments data. In terms of the population, RAND's data analysis looked at a sample of a commercial hospital spending, which equated to about 6% of commercial spending. It included about 4,000 hospitals across the U.S. over the period listed here. The federal hospital transparency data includes approximately 21% of hospitals. There's still ongoing work to increase some of the reporting in that program. OCA's data includes California's hospitals that submit a designation we're referring to as comparable. So that's if the hospitals are submitting comparable financial data, they're included in our analysis. And then in terms of adjustments that are applied to the data, the federal transparency data adjusts as a negotiated price per unit. It does not include utilization measures. RAND adjusts for volume and intensity using Medicare relative weights. Similarly, OCA uses a volume and intensity adjustment using Medicare weights. So in forthcoming slides, we'll be showing results for when we just look at volume only, and then which was a request from our hospital work group so that they could see the impact of applying an intensity adjustment. And then shifting over to the measures row, federal hospital price transparency data is measuring per unit negotiated amounts by contract, whereas RAND measures a reference-based price. That is how commercial payments compare with what Medicare would have paid for the same service. And a standardized price, that is the commercial payment per standardized unit of care using Medicare relative weights. OCA is measuring facility level inpatient and outpatient spending by payer and adjusted for volume and intensity. And this allows essentially for us to have a standard unit of care for inpatient and outpatient spending. And then lastly, for federal hospital price transparency, it's the allowed amounts per contract without any measure of utilization or volume. For RAND, it's also the allowed amounts, but from a sample of commercial payers. And then for OCA's approach, it includes hospital reported payments included in net patient revenue. So this would include the allowed amounts as well as other payment sources such as DISH and 340B. So I'll take us to our next slide. So we published the following resources that accompany this presentation. They're listed here. We include the crosswalk, a facility level data set. We have documentation on how the measures were calculated. And then we have an issue brief that summarizes key findings. Those can be found on the website. And then now I'll just cover one last slide before I turn it over to Andrew. So here's some descriptive statistics for the comparable financial hospitals we looked at. So we see here that total operating revenue, which is marked by the row with the letter A, increased 7.5% over the 2 years. And then during this time, total operating expenses grew 8.7%. The next financial measure in this table is net from operations. So this is the net income resulting from providing patient care in the hospital. So this is essentially taking total operating revenue and subtracting total operating expenses. So we see that the net from operations decreased from 1.41 billion to about 0.015 billion, which represents a negative 99% year-over-year change. We could translate this amount to operating margins. So that's essentially taking the net, the amount reported in row C, and then dividing it by the operating revenue. So those percentages translate to 1% in 2022 and 0.1% in 2023. And it shows a similar change in terms of the percent change. And then now I want to just shift gears to non-operating, so the non-operating revenue and expenses. So these are, first I'll start with non-operating revenue. So these are, refers to the revenue received for services that are not directly related to the provision of healthcare services. Some examples include income and gains from investments, various government assessments, and appropriations. And then non-operating expenses are those that are incurred for services that are not directly related to the provision of healthcare services. So these include expenses related to losses on sales of hospital property, other expenses related to operating medical office buildings or retail operations such as gift shops. So when you take the net of these two amounts, the net of non-operating revenue and non-operating expenses, this amount increased from $500 million in 2022 to $7.5 billion in 2023, representing a 1,400% increase. So shifting down a row, we have profit or net income. This amount refers to the amount of income from operations plus the figure that I just covered, the net of non-operating revenue and expenses. And then after we deduct taxes and extraordinary items, profits changed from 1.8 billion in 2022 to 7.4 billion in 2023, representing a 311% change. And then this amount could also be translated into what we call a total margin, which increased from 1.3% to 5.1% in 2023. So I'll turn it over to Andrew to go over some of the findings from our data analysis.
Thanks, Vishal. So this table on the slide will provide an overview of the number of comparable hospitals for which we have inpatient and outpatient values by payer. So as Vishal just noted, we have upwards of 360 to 368 hospitals that are designated as comparable, but we don't necessarily have outpatient and inpatient spending measures for all of those hospitals. And so this table just reflects by inpatient and outpatient measure, as well as by payer type, the number of values that are populated. So on the outpatient spending measure, you can see we have non-null values for between 292 to 319 hospitals. And then on the inpatient spending measure, we have values for between 349 to 357 hospitals. Common reasons for missing values for these hospitals include the following types of reasons. So not reporting revenue for a certain payer. So for example, a hospital didn't serve any commercial patients, we wouldn't observe any revenue for that market. Similarly, not reporting utilization in the form of either discharges or visits for a certain payer. On the outpatient side, if we were unable to find that facility in the HPD, and then finally, there may be an absence of outpatient visits with an ambulatory payment classification or APC weight in the HPD. Next slide. So this is going to be a little bit of a throwback to December. Based on hospital feedback on OCA's crosswalk during the month of February, as well as other measurement refinements, we wanted to provide an update on a set of outpatient visit summary statistics that were first shared back in December. So I'm going to focus on that fiscal year 2022, but the results are substantively similar if we forward 1 year to fiscal year 2023. And so I'll just refresh everybody's memory about those December results. So in December for fiscal year 2022, we reported finding 1.7 million commercial outpatient visits with an APC weight in the HPD out of a total of 15.2 million reported in the HAFDAR or the hospital financial data. Upon updating that analysis in light of that updated crosswalk, we saw a 76% increase or about 10 percentage point bump in commercial outpatient visits with an APC going from 1.7 million up to 3 million visits. Turning to Medicare, so back in December for fiscal year 2022, we reported finding 6.7 million Medicare outpatient visits with APC weights in the HPD out of a total of 15.8 million in the HAFDAR. After updating that analysis, we saw a 3% increase, or about 1.3 percentage points in the share of Medicare visits with an APC relative to what's reported in the HAFDAR. So going from 6.7 million outpatient visits to 6.9 million. And then last, for the Medi-Cal market, back in December, we reported finding 3.8 million Medi-Cal outpatient visits with an APC out of a total of 15.3 million. And then since updating that, we see a 37% increase or 9.2 percentage points on a proportion basis in Medi-Cal outpatient visits with APC weights going from 3.8 million to 5.2 million. So just want to take a moment to thank the hospitals who engaged with us during the month of February. I think we received well over 130 responses, both confirmatory and then corrective, to make sure we had an accurate reflection of their NPIs for that respective facility. We can move on to the next slide. So here we're going to report the weighted median inpatient net patient revenue per case mix adjusted discharge for fiscal years 2022 and 2023 across the commercial, Medi-Cal, and Medicare markets. So I'll start with the commercial market here, where we see the median intensity adjusted inpatient spending was just a little over $22,000 in 2022 and increased to $23,600 in 2023, an increase of a little over $1,500 or 7.1%. In the Medi-Cal market, the median intensity adjusted inpatient spending measure was about $14,500 in 2022 and about $14,350 in 2023. So a decrease of about $170 or 1.2%. And then looking at the Medicare market here in purple, we can see that median intensity adjusted inpatient spending was about $10,400 in 2022 and about $10,200 in 2023. So a decrease of just under $150 or 1.4%. And then we can sort of compute relative spending measures by taking the division between commercial and Medicare inpatient spending values, where we see that median commercial inpatient spending was approximately 212% higher than Medicare in 2022 and about 231% higher in 2023. Next slide. So on this slide, same types of reporting across markets, just we're going to focus on that outpatient measure, or as we're going to call it, the outpatient net patient revenue per intensity adjusted visit. And that again is going to be the weighted median for fiscal years 2022 and 2023. So in the commercial market, we see that median intensity adjusted outpatient spending increased from $215 in 2022 to $224 in 2023, an increase of $9 or 4.2%. In the Medi-Cal market, that median intensity adjusted outpatient spending measure was $160 in 2022 and increased by $4 to $164 in 2023, an increase of 2.5%. And then last, in the Medicare market, we see that median intensity adjusted outpatient spending measure was $90 in 2022 and increased by $8 to $98 in 2023 for a relative increase of 8.9%. And here again, we can compute that relative measure. So when we compare Medicare, commercial to Medicare outpatient spending, we see that median commercial outpatient spending was about 240% higher in 2022 and about 230% higher in 2023. Next slide. Okay, and as Vishal noted, one of the suggestions we heard from the hospital work group OCA convened last year was to report inpatient and outpatient spending measures wherein we're only adjusting for volume. So this would otherwise be known as inpatient net patient revenue per discharge. And so what that means is all discharges are going to be treated equally, whether it's a 1-day stint or a 5-day stint, it's all the same for the purposes of this calculation. We're ignoring the resource intensity associated with that discharge. And so in the absence of any intensity adjustment, we can see across the three markets, higher absolute inpatient spending levels with median commercial inpatient spending now well above $30,000 per discharge, median Medi-Cal inpatient spending now approximately $20,000 per discharge, and finally median Medicare inpatient spending approximately $19,000 per discharge. And when we look at the growth in median volume only adjusted inpatient spending from 2022 to 2023 fiscal years, we see a 5.4% increase in the commercial market, a 1.5% increase in the Medi-Cal market, and a 0.7% increase in the Medicare market. Next slide. So we're going to continue the theme of looking at those volume only adjusted measures. This time on the outpatient side, so looking at median outpatient net patient revenue per visit. And so as a reminder here, all outpatient visits are going to be treated equally. So a blood panel and a colonoscopy and a outpatient knee replacement are all going to be treated equally. And so in the absence of an intensity adjustment across those three markets, we again see higher absolute outpatient spending levels, with median commercial outpatient spending now well over $1,600 per visit, median Medi-Cal outpatient spending now about $800 per visit, and median Medicare outpatient spending about $650 per visit. And then when we look at the growth rates across those three markets from 22 to 23, we see a 7% decrease in the commercial market, just under a 3.5% increase in the Medi-Cal market, and a 1.2% increase in the Medicare market. Next slide. So those previous slides were reporting median growth in spending from 22 to 23. So in this slide, we're going to plot hospital level commercial growth rates for those inpatient and outpatient measures. So for visualization purposes, we did drop observations with growth rates that were below the first percentile and above the 99th percentile. I'll note, though, in the issue brief Vishal mentioned, you'll see a much more comprehensive suite of summary statistics, including mins and maxes, so you can get a full range of that distribution. So after censoring those extreme values in the top and bottom percentiles, we do still see substantial variation in growth rates, ranging from 50% decreases in some instances to over 100% increases in others. And I'll just flag again, as Vishal noted earlier, these data are available on OCA's website for those who would like to explore it on their own. Next slide. So the figures on this slide will plot the hospital level Medicare growth rates for inpatient and outpatient measures. Here again, these S-shaped curves are going to look awfully familiar. So still having dropped that top and bottom percentile, we do still see substantial growth rates in both directions. So ranging from pretty large decreases in the range of 40 to 50% to fairly large increases on the order of above 50% as well. And just for completeness, on the next slide, we're going to plot those hospital level Medi-Cal growth rates for the inpatient and outpatient spending measures. And yet again, those S-shaped curves should be familiar by now, where you see fairly sizable decreases as well as fairly sizable increases on the right side of the zero. Next slide. So on this slide, we're going to report some summary statistics of commercial inpatient and outpatient growth rates across a range of growth brackets. So recognizing that there was no spending target in place during this measurement period, with obviously that important caveat, we found on the inpatient side, rather, so out of the 352 facilities for which we reported a commercial value, 185 facilities, or 52%, had commercial inpatient spending growth at or below 3.5% during that 2-year stint. On the outpatient side, out of 309 facilities, 154, or 50%, had commercial outpatient spending growth at or below 3.5%. And then obviously, as you matriculate through to the lower rows of that table, you can see that on the top end of the distribution across both the inpatient and outpatient measures, about 10% of hospitals had growth rates at or above 50%. Next slide. Okay, as we're often wont to say, any analysis that we undertake is going to have some set of limitations. So we're just going to hands above the table and share a couple of those for awareness. So both the inpatient and outpatient spending measure calculations depend on hospital reported net patient revenue values as well as allocations across payers. And in many instances, oh, can we go back one? Sorry. Did the limitation slide get censored? I promise that wasn't me. I can speak to them, but it feels like I'm being furtive by not actually putting it on the screen. Okay.
In the post is
It's just an accident. Give us a second.
That's an awfully inauspicious slide to hide, but okay, we will move on. So moving on, you'll have to trust me that the slides do in fact attest to these limitations. So I'll just reiterate then on that first one. So both the inpatient and outpatient spending measure calculations depend on hospital reported net patient revenue values as well as their allocations. But it's often the case that these allocations are based on both projected or expected sources of payments in the hospital financial and patient discharge data respectively. And so those could be subject to change as those claims get adjudicated through run out. Next, as we've discussed in the past, California's healthcare payments database does have limited data from private self-insured plans. And so to the extent self-insured commercial enrollees use hospital outpatient services in systematically different ways than fully insured commercial enrollees, the average visit intensity calculations could be subject. How about that? Okay, it's now up there. So the average visit intensity calculations could be subject to measurement error. Moving down to that third bullet. So we used CMS's outpatient prospective payment system, or OPPS, ambulatory payment classification, or APC weights, to define intensity. But some types of claims do not have an APC code assigned. So for example, some newer services, so back in 2020 and 2021, COVID vaccinations, for example, may not have an assigned APC, or the service may not be considered payable under the OPPS. So services provided by federally qualified health centers, rural health centers, as well as end-stage renal disease service centers aren't subject to the OPPS system, and thus APC codes wouldn't be assigned to those claims. Next, we calculate outpatient visit intensity as best as possible, trying to adhere to the hospital financial report definitions in Chapter 4000 of the accounting manuals. Though there could be variation in interpreting instructions across the 360 plus hospitals, and we want to acknowledge that. And then finally, this is only a 2-year period from 2022 to 2023 fiscal years. And so it doesn't enable us to understand long-term trends in both spending levels as well as growth rate variation. And taking us home on the next slide. So just to wrap up then, as part of OCA's continued commitment to transparency, we posted on a website that revised crosswalk, Vishal noted, that incorporates hospital feedback, documentation on how it is we derive these measures using a litany of different data sources, that facility level data set that includes measures for payer specific inpatient and outpatient spending measures for the commercial Medicare and Medi-Cal markets for those 2 years in 2022 and 2023. And just as a reminder, median commercial inpatient MPR per CMAD increased by about 7.1% from $22,000 to about $23,600 in that 2-year period, which is well above 200% of median Medicare inpatient MPR per CMAD. On the outpatient side, we found that median commercial outpatient MPR per intensity adjusted visit increased by about 4.2%, which again, when we compare levels, was well above 200% of median Medicare outpatient MPR per intensity adjusted visit. And I'll note, OCA intends to continue to report on hospital inpatient and outpatient spending measures annually as new hospital financial data become available each fall. Next slide. And just to wrap us up on the timeline or the cadence with which data become available and can subsequently be reported, below is a table that shows OCA's planned annual reporting schedule. I'll note that data for that first enforceable target, the 2026 performance year, will be submitted in fall of 2028 and reported in spring of 2029. And then looking ahead, in light of that substantial variation, both spending levels and spending growth across hospitals, we certainly intend to explore factors underlying these patterns, including but not limited to hospital level characteristics, as well as regional market dynamics. In addition, just given how fruitful that engagement was with hospitals this past February, as we prepare to analyze fiscal year 2024 data, we'll once again seek input from hospitals to ensure we have an accurate mapping of their NPIs. So with that, I'll turn it back over to the chair to facilitate discussion.
Thank you very much for that presentation. Questions and comments from the board? Ian and then Rick.
There's a ton of great data in here. I just want to make sure my takeaways are correct. To me, the headlines seem, so the commercial ratio to Medicare, you know, in the inpatient, for example, went up from 212% of Medicare to about 230% of Medicare. That's bad. But if I understand correctly, it's around about 20%, give or take 20% of facilities that are driving the disproportionate share of that growth. Is that fair to say?
I don't think it's going to be driven necessarily by a small subset of facilities. I think we plotted the, in the issue brief, we did plot those respective ratios, and there's quite a bit of heterogeneity there as well. But just when you take that sort of median point, it reflects that well above 200%. But there's going to be some facilities that are well below 200% and some facilities that are well above that 200% some odd relative point.
I guess I got the 20% just looking at the number that were, 20 to 50+% of growth rate overall. So thanks for that clarification. Also, north versus south, other regional observations? Is it similar statewide or what?
It's a great question. So the data set that we posted online doesn't have regional any sort of regional variables in it. We did include facility numbers, so we certainly don't have a monopoly on any sort of wisdom or insight. But the inputs are readily available on that data set, such that if somebody wanted to join it back to the complete data set to retrieve address or location information, that'd be available. I confess that was not, we didn't have a chance, just given the tight timelines, to explore sort of potential variation across any number of hospital level characteristics or regional characteristics. That is on, I think, on the roadmap for us going forward, though.
Thanks, Andrew. Just, tremendous work in getting this far. Thank you for posting the data set, and I congratulate also on posting the methods document. I mean, I review many papers. It's rare that you could actually reproduce somebody's analysis from what they described in methods. And although I haven't tried, I think I probably could reproduce it from the level of detail that you provided. So that's really phenomenal. I do have some concerns about the data. And two main kind of yellow flags, at least, or results that raise some questions for me. One is the relative revenue per inpatient adjusted, per CMAD, per case mix adjusted inpatient admission for Medi-Cal compared to Medicare. And then similarly, revenue for per outpatient adjusted visit for Medi-Cal compared to Medicare. The Medi-Cal inpatient revenue per CMAD is estimated about 40% higher than the Medicare revenue per CMAD. And on the outpatient side, about 60% difference. And I know there's, been, some discussion and concern, and concern in some places about Medi-Cal paying more than Medicare, and what would happen if it comes down. But that level of difference seems high and makes me wonder a little bit about the data. And then the second sort of cause for some concern is the wide variation in year-to-year change in Medicare revenue per CMAD on the inpatient side and per outpatient adjusted visit on the outpatient side. And the way the Medicare payment system works, there are some changes across hospitals from year to year in relative payments. If a hospital increases its number of residents per bed, its payment is going to change somewhat differently than the hospitals that are not teaching hospitals, or hospitals in areas where the wage index has gone up more than in other places may see, bigger increases in Medicare revenue. But for the most part, Medicare revenue per discharge and per intensity adjusted outpatient visit, I think, should change relatively similarly across hospitals. And that sort of S-shaped results that you showed, suggest pretty big differences. And some of that may be small hospitals. And so if that kind of narrows a lot, if the S has less shape to it, when we limit this to larger hospitals, that would be reassuring. But I think that sort of going forward, some more attention to what's causing these patterns is probably needed. As we, as we've discussed a number of times, these data weren't originally intended for this purpose, and we're now using them differently, and it may take some time to kind of wrestle them into shape that they can really be used competently for this purpose.
Yeah, no, tons of great feedback there. As a caveat, I don't anticipate I'm going to be able to satisfactorily answer or provide satisfactory responses to that. What I will note, as we were developing those figures reflecting the hospital level growth rates, the reason for censoring those distributions was because there were a number of facilities, a very small number of facilities with growth rates well in excess of several 100%. And when you explore what's going on under the hood there, I think a lot of it seems to be an artifact of what I noted on the limitation slide. So hospital reported net patient revenue values and allocations could sort of bounce around from year to year. And so if you anticipate you've got a windfall of commercial enrollees, but it ends up that they transition over to Medicaid once everything the dust settles, that's going to be reflected in their updated financials. And so there can be quite a bit of lumpiness in reporting of both inpatient and outpatient revenue. That's but one reason for these really extreme outliers. But I think there's a lot more work that we can do to just understand the full scope of possible explanations that could account for 50% decreases and 50% increases, just so we have more confidence using the data going forward.
So actually sort of winding all the way back toward when you started with the descriptive statistics for comparable hospitals. So basically, I mean, we only have 2 years here, 22, 23, and essentially the operating margin is fairly small. I mean, we went from 1% to 0.1%, right? But what I'm curious about is the non-operating revenue expenses, because those are much larger, and you went from 0.5 to 7.5 billion in 1 year, and we only have 2 points. How volatile is that number? I mean, does that go from 0.5 to 7.5 back down to 0.5 to whatever, or does it? I mean, so I don't know if I realize you only have the 2 years here. Do we have a sense of how much that swings back and forth from year to year, or is this growth or whatever? Because essentially it seems like that's what's driving the profits. They're non-operating revenue, which basically that tells me the lesson to the hospital CEO and the board is that focus on that, not on patient care.
So yeah, that's a great question, and it's one that can be addressed. In this particular case, we just tried to align those descriptive statistics with the 2 reporting years, but we could look to prior complete data sets to get a better understanding of how some of those values would evolve on a longer time series. But I don't have those responses offhand, but we could certainly follow up with you offline.
Okay. Yeah. I mean, again, as we're looking at cost targets and stuff like that, I don't know how this folds into it, but it looks like, the margin is driven not by patient care, it's driven by whatever else isn't, right? If there's a big swing every year, depending, I remember reading an article, this was many years ago, that, for example, Sutter reported that, that basically their entire profit was basically the returns on their reserve investments or whatever. It's not from it's not from patient care, right? Which is supposed to be their main line of business. So, and that might actually drive certain types of behavior if people are looking at the physical situation in the hospital, but most of it's driven not by patient care, but by other things that they do outside of patient care that might generate revenue.
I was gonna make a similar ask about looking at multiple years, just because I think that there was a blip in 22 or 23. It was 22. And it's just helpful to see the context. We saw some really weird things happen in our rates that year, and the reported operating margins were similar, but it wasn't a trend, or you couldn't use it to say anything meaningful about trend.
Not seeing anything else from the board. We are going to go ahead and open this up for public comment.
We'll now take public comment on this item. Please step to the podium or raise your hand virtually. And I believe this is our last agenda item, so we can also take general public comment at this period. Seeing no hands raised virtually, I'll go to the podium.
Green is on, right? Yeah, okay. Hi, I'm Victoria Valencia with the California Hospital Association. Thank you for the opportunity to comment today. The data reviewed here highlights several challenges in measuring hospital spending and accounting for key factors like volume and acuity. They also offer an early snapshot into the pressures that hospitals face in keeping reimbursement aligned with rising costs and persistent shortfalls in government payers. First, on the non-operating revenue that was presented today that some of the board members have commented on, that year 2023, that large increase, that year indeed was an anomaly. If you go back and look at the non-operating revenue across time in the AFDRs back a number of years, mainly driven by a huge decrease in 21 to 22, a 95% drop from 21 to 22, making the subsequent 23 year look like that large growth we saw today. Second, the data show enormous variability, also highlighted by some of the board members today, in the annual growth at the hospital level. For the first time, we see that this volatility extends to the outpatient setting under OCA's methodology. While the slides noted that about half of hospitals fall below the 3.5% target, if you look at the full distribution, it tells a different story. Roughly 200 hospitals have growth below negative 10% or above positive 10%. While we have only 1 year of outpatient data, CHA's analysis of inpatient data suggests that this is not driven by persistent differences in performance, but by year-to-year enormous volatility that must be accounted for when evaluating hospitals against spending targets. We also looked at the largest decreases in Medicare and Medi-Cal, as seen there in the charts we saw today. And it's not only driven by small hospitals. Those large decreases in year-to-year spending include hospitals that have low discharge volume and hospitals that have large discharge volume. So it's not just a small hospital problem. Next, we appreciate the improvements in the alignment between the HPD and the hospital financial reporting, likely reflecting the recent NPI mapping efforts. However, the commercial visit coverage remains worryingly low at about 20%, which may be contributing to the volatility that we observe today in the spending growth. We look forward to continued collaboration to ensure that HPD data used for intensity adjustment is complete and representative of hospitals' experience. Next, the divergent growth patterns across payers underscore the importance of evaluating hospital spending growth globally and accounting for factors like payer mix. While commercial spending growth exceeded the target in this report we saw today, we estimate all payer growth was roughly 3 percentage points lower, well below general inflation for this period overall. This reflects that higher commercial payments continue to be needed to offset shortfalls from public programs, something that cannot continue to be ignored. Thank you.
Thank you. Looking virtually, seeing one hand raised. Angus, you should be unmuted. Go ahead.
Hi, good afternoon, Secretary Johnson and members of the Healthcare Affordability Board. Thanks for the opportunity to provide input to the board today. Angus Cochran with Washington Health, Independent District Hospital in Southern Alameda County. We were disappointed that the OCA board did not take action at the March board meeting to establish a policy for removing hospitals from the high-cost provider list when the financial data that they submit to HCI shows they no longer meet the criteria for being on the list. Earlier this year, Washington Health resubmitted financial data for the years 2021 through 2024 to the HCI Hospital Annual Financial Disclosure Report, the well-known HAFDAR. This resubmission clearly demonstrates we no longer qualify for inclusion on the list. The data which was accepted by HCI was not changed in the aggregate, but was recategorized based on industry standards relating to payer categories. And as you heard from a member of the HCI data team at your March board meeting, hospitals resubmit data over 100 times each year, many correcting misinterpretations in payer categories. So it's hardly unusual for a hospital to submit HAFDAR data to HCI. So I'm here today with two requests. First, please require the OCA staff to prioritize the consideration of data resubmissions in modifying the high-cost outlier hospital list. When a hospital demonstrates it does not belong on the list, it really is unacceptable. It has to wait 12 to 18 months to be removed from the list. And second, we would ask that the OCA staff make a public statement in writing at a forthcoming OCA board meeting that affirms that Washington Hospital no longer belongs on the high-cost list and will be removed at the earliest opportunity. A public acknowledgement such as this would really help mitigate the reputational damage being incurred by our hospital. Thank you so much for your consideration today.
Thank you. Back to the podium.
Thank you, Beth Capel for Health Access California. We appreciate seeing this data and actually opened the Excel spreadsheet this morning, probably an error, and look forward to doing more analysis of it in order to understand the implications. A couple of things to note. This is limited to what are called comparable hospitals, which excludes psychiatric hospitals, which when we looked earlier were among the most profitable and where there were clear patterns of driving profitability at the expense of quality. So that raises questions on its own. It also currently excludes Kaiser hospitals, although those are coming online. So those are two major exclusions. Some of the others make sense. There are some. We're a big state. We have some unusual hospitals. We would, while we understand the temptation to use the category of comparable hospitals, a categorization that dates back to when Pete Wilson was governor, we do think that OCA may require a broader view as we're moving forward. We were also very troubled to see a substantial share of hospitals with growth that was so large. 10% of hospitals with revenue growing more than 50%, that seemed like rather a lot. 20% with more than 20% growth, that seemed like rather a lot. We do want to make sure the data is valid and accurate so that we are basing any decision, this board is basing any decisions and we base any recommendations on accurate data. We think that's important, but it certainly raised our eyebrows. Thank you. Oh, and one point as a point of personal privilege, I am told by somebody from county land that JPAs are in fact subject to the Brown Act. So, but do investigate because my recollection is that JPAs are not subject to the same public scrutiny as a district hospital or the University of California. Thank you.
Thank you. Seeing no hands raised virtually, looking to the podium, go ahead.
Hi, good afternoon. Anate Miller speaking on behalf of the California Association of Health Plans. For general public comment, we have a few items we wanted to address. First, we support OCA's efforts to improve transparency and accountability, and we appreciate the opportunity to engage as the office moves from development to implementation. We want to briefly underscore one point that is not explicitly on today's agenda, but is central to public understanding and did arise in earlier discussions. When OCA presents payer administrative cost and profit information, whether in a formal report or a short slide summary, it is important to provide the underlying methodology, definitions, and limitations so the board and the public can interpret those figures accurately. Excuse me. In today's hospital spending materials, OCA appropriately highlighted limitations and context that guide interpretation. We respectfully encourage a comparable approach when presenting payer financial data, particularly where results are aggregated across markets or derived from MLR-based reporting. Second, as the board continues shaping spending target enforcement, we encourage OCA to build a framework that is transparent, forward-looking, and mindful of alignment with existing regulatory requirements and oversight structures, including the nuances of MLR and rate review processes, so that policy signals are clear and implementation remains grounded in statutory authority. Third, on data submission enforcement, we just wanted to note that we appreciate OCA incorporating stakeholder feedback and recent refinements, and we see encouraging signs of flexibility as OCA develops regulatory text. We intend to submit further written comments on the draft emergency regulations, and we respectfully reiterate the importance of considering operational impact of evolving file requirements and changes over time, especially as OCA defines completeness and related enforcement triggers. Thank you for the opportunity to comment, and we look forward to continued engagement.
Thank you. We'll go to Robbie. Your hand's raised virtually.
Yes, thank you. Robbie Francescini with Blue Shield. We just wanted to provide additional comments today on the topic of administrative costs and profits. We do support holding all of us entities accountable for our spending increases in line with the targets, but did just want to piggyback off of our colleagues' comments on the issue of previews of data and the publishing of data on administrative costs and profits, and wanted to emphasize the importance of including context and detail around the components of this spending, what may be driving it, and additional details on the data sources of these data too. We really do appreciate the opportunities we've had to provide additional ideas and recommendations to staff and look forward to continuing to do so. Thank you.
Thank you. Looking to the podium, seeing no one at the podium and no hands raised, that concludes public comment on this agenda item and also general public comment.
Thank you very much. Board members, thank you for your continued engagement and commitment to our goal here. Staff, thank you as always for your excellence in preparation and presentation. And public, thank you for your engagement and your voices being lent to this conversation. We will see you at the same time, same place, at a different date, May 27th, for our next board meeting. That the meeting's adjourned. Thank you.